private hospitals in Baringo County. And, we have people from Kwale, from Kakamega, they're here, and they're all offering services to Kenya. But critically, these members have been committed because of the nature of our populations where we serve to offer these services on a non-co-charge basis. And as long as, this is private investment, but as long as we are committed to that goal of making sure every Kenyan has access, we find that there's a lot that has brought us together. In essence, that is the spirit of Rupha. And as the healthcare landscape changes, as it changes rapidly, we think that we as an association also have to innovate. And that is why we have come together to discuss today. So that is for us, the sake of our guests and visitors. I don't know whether Dr. Elizabeth Gitau has joined us now. Not yet? From KMA? Right. So I believe that we have had some time to settle in. So it's about 10:40, so that we don't run so much behind time. I don't know whether Dr. Kuhora, you've caught your breath. You've got your breath? Okay, thank you, Sana Daktari. Dr. Kamunyo, the CEO, was to be the first speaker this morning. I think I will ask somebody to pass. Can you please pass our guests copies of the program so that they can stay abreast? Please pass. Right. So I believe that. Oh, you have it. I believe that we have had some time to settle in. So it is my pleasure, ladies and gentlemen, to introduce Dr. Samson Kuhora, our friend from the National Hospital Insurance Fund. Have you guys interacted with Dr. Kuhora? Can I see by show of hands? Anybody who has interacted with Daktari? Daktari, there are too many people, new people to meet you today. From the lack of show of hands, you will make new friends today. I want to welcome you to introduce yourself and our colleague, and then you can make your remarks. Dr. Kuhora called me in the morning as he comes, and he said, the CEO just told me not long ago that I am the one speaking. Then he asked me, what am I speaking about? So I had to assure daktari akuje tu afungue roho ama namna gani? Aseme tu ile itakuja kwa akili, eh? Yes. We are very much interested as private sector players in health in UHC. We know there's a lot of conversation around UHC. And as far as we can tell, UHC is going to be carried along with run by the National Hospital Insurance Fund. So one of the things we really were keen to hear from, considering that Saturday is World UHC Day, is how does NHIF see the role of private healthcare providers in championing UHC? I think UHC is going to be a big discussion in the coming years, next year and going forward. And we are ready, as I said, our model is non-copay, which is essentially the discussion around NHIF. But we would like to hear from the NHIF how they see us playing a role in helping Kenyans access universal care. And I think there's a lot to talk about that. So Dr. welcome. How does NHIF see the role of private healthcare providers in championing UHC? I think UHC is going to be a big discussion in the coming years, next year and going forward. And we are ready, as I said, our model is non-copay, essentially the discussion around NHIF. But we would like to hear from NHIF how we see us playing a role.
Okay, good morning. Thank you for the session. We are hoping to have a very good engagement. I think not so long ago, I got a request from Rupha about the recontracting exercise that we are in the process of doing, because as you are aware, The contracts that we have are expiring in June next year, and we've already started the process of engagement so that we can get your feedback and also have contracts that address the concerns that you already have at the moment. I think the response that I gave to him is that we intend to have several stakeholder forums, and I would like to believe this is going to be one of them. And then we have a national forum as well that we bring in different stakeholders, and we have a similar engagement. So this is a good morning. I think we've started from somewhere, and we are hoping to have more forums. So for myself, I'm Dr. Samson Kuhora. At the moment, I head benefits and claims at the fund. It's responsible for the product development, for empanelment of the different providers, both locally and internationally, the payments in terms of claims, and the quality assurance aspect. My colleague is Douglas Odhiambo. He's specifically responsible for contracting at the moment. He'll probably give us a word about what he's doing at the moment. So, Karibu. Different stakeholders, we have a similar. So this is a good morning. I think we've started from somewhere.
Thank you, Doctor. Good morning. Okay, I'm Douglas Odhiambo. Currently, I'm in charge of quality assurance and contracting at NHIF. But I've also served in various positions at NHIF, starting with regional manager, Southern Region. I know I may have met some of you. Southern Region is the former Coast Province, combined with Kitui and Makueni. That is based on our administrative structure. Then I've also served as regional manager, Rift Valley Region, before I was moved to the head office last month, as now the manager, quality assurance and contracting. I know I may have interacted with some of you in my previous jobs. Before joining NHIF, I was the head of risk and quality at KNH for about 7 years. So I know I must have engaged some of you who may have, the doctors who may have been at KNH. As my colleague have said, we are going to another period where most contracts are expiring, and we have to renew them before June next year, 2021. And we are not just going to renew them, we have to reassess all the facilities that are contracted by NHIF. And the reassessment is based on the similar standard. We are going to use KQMH, Kenya Quality Model for Health, and of course, accompanied with a checklist. We'll be engaging, as my colleague has said, so that we can get feedback from you, so that we go through a very objective and a fair process. But what I want to ask from us all, you need to prepare yourself. We get quite a lot of requests midway that I want to introduce a service. I want to add this service. I believe as owners of various facilities, you must be running it strategically, of course. I mean, you must have a plan. You must have a strategic plan, which will be running for a specific period. You must know what you are putting in place. So my request is that as we approach the recontracting period in June, ensure that at least by latest March, you put all the things that you want to do in the next contract period. So when we come, we capture everything. You're aware that doing a contract is not easy. It involves a lot of expertise, resources. But we've been so good because we take care of the costs. So basically, our request to minimize a lot of necessary expenses, ensure that by the time you're coming to the ground, you are ready with all the equipment, the services, so that we capture everything that you want to do in the next contracting period. Otherwise, I know you have so many issues regarding contracts, regarding assessments and all that. We are here to engage. Just 2 weeks ago, I talked to Dr. Brand. I wanted all your contacts, your updated email addresses, updated phone numbers. I don't want personal phone numbers. If we can have the phone numbers of the facilities, because if you give me the phone number of the CEO, that means you change them. So we wanted the phone numbers and the email addresses so that we can be even having more of these engagements virtually because, you know, the new normal has created a platform for us. We don't have to wait for physical engagements. Currently, we are engaging based on counties. Just last week, we engaged the Voi County. We had a good meeting with the facilities and our branch there and the regional office there. As I speak, we are talking to Muranga County. I've just left that virtual meeting. We are engaging them with our teams on the ground. What we are trying to do is to bring services and effectively communicate to you, because most of the things that happen is because of information is not flowing. We are aware information is business. So if you don't get it, it becomes bad business as well. So what we're trying to do is to ensure that we give you the information that you need. You don't have to travel to Nairobi. We want you to attend to patients down there. So we don't want you to travel all the way to Nairobi, spend all the monies, just to look for something that you could get through a phone call. We don't want that to happen. And today, as I told you, we are engaging Muranga, and tomorrow we'll be going to Kericho. So if you are having a facility there, we'll still escalate this engagement virtually. So thank you very much. We are looking forward for working together. I want to say this. We should work as one, because the most important thing is the patients, our people. So what we're trying to do is to ensure that, and actually most of our clients, they interact with you mostly more than NHIF. So you should become the champions in terms of the agenda of UHC, and of course, any other thing that is coming up. So let us work together, let us move together, not us and them. We are together in this journey. Thank you very much. Thank you very much.
Okay, thank you. Thank you for giving us a brief. And also the critical part, information is very important, because a good number of times we end up having issues because we either have incomplete information, wrong information, or no information at all. So in this presentation, I would wish to take you through what we envision as a UHC. In as much as it is amongst the big four agenda for the government, there are ways in which we have suggested it be rolled out. And we've appreciated the role that the private sector plays as far as healthcare is concerned. I think especially now that there are a number of issues when it comes to accessing care or accessing quality care in government facilities, either perceived or real, there is a significant role that the private sector plays. So when we're looking at exactly which role do we look at, we've compared reports from 38 different countries on what has been happening. We've also looked at published reports and a forum, or rather an engagement at the World Economic Forum last year that sought to define what the private sector should be doing as far as healthcare in different countries is concerned. So I'll take you through where we are as an organization, where we are intending to go as far as UHC is concerned. And for the section on the role of the private sector, I would like to request that we have a good discussion on that. It is not a policy document yet, but it's something that we are developing with you in mind. And also the private sectors, and we've sought to define exactly what these private enterprises are. So as a journey, our mission is basically to contribute towards UHC in the provision of affordable, accessible, sustainable, and quality healthcare. I think sustainable is very key because it has been one of the cornerstones of some of the activities that we've had to do in the recent past. We have to look at whether we can be able to sustain what we are offering as an organization. Remember that our main funding source is the premiums that are paid by the members. Therefore, the contributions would have a significant implication in terms of the resources that are available. As a fund, it was basically started in 1965 as a sessional paper, that proposed the establishment. And over the years, it has gone from just a fund as a department within a ministry to a fully fledged parastatal under the State Corporations Act in 1998. We rolled out the civil servant scheme in 2012. And in 2015, we had a huge scale up in terms of the premiums that were paid, in terms of the benefits that were being offered, and in terms of the different programs that were enrolled within the fund. And in the recent past, we've had several other engagements that are geared towards the universal healthcare. So in terms of access to services being offered by the fund, we have a service network of 156 points. Those are the branches, the satellites, all Huduma centers, and probably what is not enlisted here is the regional office, which my colleague mentioned he was responsible for. Then in appreciation of technology, because we have to embrace technology to be able to survive in the current world, we've rolled out electronic platforms. This is what has already been done. In terms of the mobile phone access, there is the USSD platform, there is the My NHIF app, there is the website, and I would like to believe for those of you who have updated their contacts within the system, anytime your card is used, you actually get a notification for the same. So going forward, there are those things which have been proposed, and one of them is very relevant to you. We are looking at an e-contracting process, where from the point of application, you actually go online, you are met with all the criteria, the general conditions, the specific conditions for you to offer particular services. You start your application, and you can be able to track your application from the point of application, whether it's at the branch level, whether it's at the regional level, whether it's at the HQ, whether it is pending board approval, the response that has been given, whether there is an additional document that is needed, whether it is at gazettement level at the AG's office, or whether the contracts are being prepared. And for those of you who've been asking about contracts, there are 82 contracts which are currently being prepared for facilities that were empaneled in the recent past. So that is being done, and we're expecting that the communication will be made through the branches in the near future. Then, of course, the call center as a way of responding to the beneficiaries. They need to know what they're entitled to. They need to know what the fund takes up as a liability. They need to know the services that are being offered in different providers. And going forward, we are expecting that we'll be able to embrace artificial intelligence even better when it comes to responding to customer needs. As far as resources are concerned, for facilities that were empaneled in the recent past. So that is being done, and we're expecting that the communication will be made through the branches in the near future. Then, of course, the call center as a way of responding to the beneficiaries. They need to know what they're entitled to. They need to know what the fund takes up as a liability. They need to know the services that are being offered in different providers. And going forward, we are expecting that we will be able to embrace artificial intelligence even better when it comes to responding to customer needs. Yes, in terms of the resources, I mentioned that our main revenue source is the contribution by the members. So we have these pooled resources, and at the moment, we are doing about 70 billion a year. So there is that which is contributed by the national scheme, also called the super cover. That's about 38 billion. There are the managed schemes, that is the civil servants, the police, the prison service, and other enhanced schemes, which contribute about 14.3. There are those sponsored programs like the Linda Mama, the HISP, they contribute about 2.3 billion. And then there is specifically Linda Mama because of its uniqueness in the sense that it takes care of individuals who are not members of NHIF, and it is specific to maternal care. That's about 6 billion per year. So when it comes to the contributions, there are those ones which are statutory contributions. That is for every employed member or every employed citizen. There are the informal sector contributions, which are also voluntary. And then there are those ones who are sponsored by government or the county governments for the poor and vulnerable populations. Now, in terms of the membership, at the moment, we are looking at a cumulative cover of about 22 million beneficiaries. And with universal healthcare, the target is actually the whole population of the country. And the current average family size is about 2.9, that is a member plus about 2 beneficiaries or dependents. Now, in terms of the growth over the years, over the last 6 years, we've increased the membership from about 5.5 million principal members to about 9.1 million. That is in terms of the cumulative figures. But then the challenge comes when it comes to retention, because when it comes to the informal sector, the retention is poor. Let me just be blank about it. The retention is quite poor. And we are looking at figures of about 35%. And when you look at up-to-date payments, the ones who actually make their payments the way your caretaker collects the rent, then we are talking about 11%. So that is a significantly low figure when it comes to the informal sector. It's something that is expected because it's what happens in most other countries, but then we have to come up with ways of supporting each other to retain this membership over a longer period of time, because it directly impacts on the revenues that are available for payments of the benefits. In terms of the providers, we have a pool of about 8,189 providers, with a majority of them, that is 70%, being government, and the private sector having about 2,107 providers, or rather 2,107 providers. That's about 26% of the whole population, or rather the whole different providers who our members access the services from. So you can see the kind of contribution that you make when it comes to access to the services. I'll talk about the benefit payout because it's one of the things that significantly impact on sustainability. We mentioned that as one of our main things that we have to make sure that we establish. In the last 5 years, in 2015, 2016, the payout ratio was about 46%. It rose to 75%. Yeah, it rose to 75% in 2016, 2017. Rose again by another 4% in 2017, 2018 to 79%. It was at 100% in 2018, 2019, and we managed to reduce it down to 91% in 2019, 2020. Now, the payout ratio is basically the proportion of the income revenues that are used to pay for the medical benefits without looking at any other cost, the admin costs or any other costs that we incur as a fund. So when it comes to last year or the last financial year, we were seriously querying the sustainability. And that is why you probably realized that we've had to tighten a number of belts, because one of the reasons why we are having this kind of payout is because of the leakages within the system. So don't see it as a punishment. We just had to take drastic measures at some point. And when we are looking at what we can do as the private sector, you actually have a role to eliminate, let me call it the naysayers within yourselves, because there are those providers, if you look at the data that we have at the moment, there are those providers who you can actually red flag. Now you have a role as an association to actually correct this, because it directly impacts on what we are able to offer as a financier. So the direct role of NHIF in the scale up, in as much as it has been a government project, the fund has been mandated to take it up and finance it through an insurance model. So the next phase of the phase out, or rather of the scale up, will mainly focus on a sustainable output. I think this is the third time I'm specifically insisting on that. There is the aspect of sustainability that needs to be achieved. Then the second bit is the national and county governments, because of the rollout, they need to inform us on the vulnerable populations or the households that has been going on since October. Because with the rollout, at the onset, we are expecting to cover the vulnerable population and them being financed to the government. There are those ones who can be able to contribute, therefore they're expected to make the contributions. And there has been a proposition on partial subsidies for those ones who can meet part of the cost, part of the premium costs, but then somebody else needs to meet the other part. When it comes to access, the beneficiaries will be able to access the different benefits at the eligible healthcare providers who have been empaneled by the fund. Rupha as an association has a critical role to play in this. As I mentioned at the onset, we are starting with the vulnerable populations, but we are expecting to roll it out to the whole population. And with time, the current sponsored programs are expected to be merged within the UHC, and they will enjoy the benefits that are currently or have been proposed for the UHC. So what are these benefits? It's basically what the current national scheme membership enjoys. But then this is the proposed package, but it has to be merged by looking at the cost simulations. We have to look at the different costs. We have to look at the different scopes. We have to appreciate that there are specialists within ourselves. Therefore, they would be offering specialized or tertiary care or secondary care. And then there is the primary health care that needs to be offered at a different level. As far as the journey is concerned, for the beneficiary and for the provider, there is the enrollment process for the members. They need to be enrolled. And if you've been looking at what has been going on in the recent past, we've been looking at having biometric registration of these members so that we can eliminate the aspect of impersonation. And then, of course, augment that with technology in terms of SMSs so that we can be able to get a response or the member can get a feedback whenever their card is used. And we are hoping to do the same when it comes to the doctors within the system. We've been talking about credentialing, where all providers will be required to declare the doctors or the healthcare workers who are working within their hospitals. Then from there, anytime a notification or something is requested by that particular doctor, you should be able to get a response that this and this is being requested, and this particular date, and this is the beneficiary of that service. So that is what is being done, and that is what is being planned. For the treatment journey, we are going to have another round of engagement when it comes to the costing, because it's one of the things that we need to address. In as much as we are looking for sustainability, we also have to offer a package that we know you are able to offer as an individual who is running a hospital. We'll be looking at coding benefits and packages, and a good bit of that has actually been done. We are looking for input from the different sectors so that we can formalize it. There is the empanelment and declaration of different hospitals that has been an ongoing process. And for the next contract, 3-year contract cycle, 2021-2024, my colleague has mentioned what is being planned. Then there is beneficiary validation using biometrics that has taken off. And then there is the pre-authorizations. That has been a thorn in the flesh for quite some time. But then we can see the impact that it has had over time. So we intend to strengthen this process because it needs to be there. We just need to strengthen and seal the gaps that are still there within the process. Then we're looking at going entirely paperless. And this is through an electronic system, both for the claims I mentioned about the contracting process. Then we intend to have a seamless way of developing packages so that by the time we get to mid-2022, we already have a good plan of what we intend to roll out for the 2024 to 2027 contract cycle. So we have a mid-cycle engagement. We bring in all the stakeholders, be they the members, be they the providers of the service, be they the government and other stakeholders. We have a national stakeholder forum, and we get your feedback on what is needed as far as what you are seeing on the ground is concerned. So that should be able to help us develop packages which are actually relevant to the communities or to the population that you are serving. And then, of course, the data. There is the monitoring aspect that we need, and this would be informed by the data. We've already made some provisions on minimum data sets. So when we go fully electronic, if some data is not provided during a request, you'll find that request bouncing and being sent back to you. And that is because we need a specific set of data to be able to inform what we're doing as far as monitoring is concerned. So that should enable us to do a networking of all the healthcare providers to support the referral system that is there in the country. We are looking at the hub and spoke as a way of doing it within a catchment. We are looking at deploying business intelligence tools and analytics so that when we are having this kind of forum, we can actually talk about the different disease patterns. We can talk about what we are seeing, the trends that we are seeing across different providers, and the measures that we are taking to address what we are seeing. We also want it to be a bit more transparent when it comes to reporting. It should not be coming out of this forum that this is the payout that we are getting over this period of time. As a relevant stakeholder within the forum, we want you to be able to have a forum where you can actually see and interrogate the data that we already have, so that as a stakeholder, you can actually do something about it or play your part in terms of addressing the gaps or what we are seeing. Then, of course, there's the aspect of fraud, wasted and abuse. It's been said that it's difficult or almost impossible to eliminate medical fraud, but there's a way in which we are interrogating it by coming out with a fraud index. And then if a provider has a very good performance indicator, then we should be able to reward you, either recognize you or, there is the carrot and stick. Let me not give the details, but that is how we intend to address it. It needs to be a performance where we look at the fraud index, we look at the assessment indicators. I mean, if you've invested laparoscopy to be able to inform some of the procedures that you're doing or make them more efficient, we should be able to recognize that investment compared to somebody else who would rather just go for open surgeries. Then there is the aspect of medical records as the third performance indicator that we are intending to look at. And that should be able to inform what we are doing as far as payment for performance is concerned. It's going to come up in a later slide. So this is the strategy that we have taken. Overall, the goal is to increase the efficiency, the standards and quality of service, and in the provision of government and private-owned facilities. I think that was excluded from that. There is the input-based financing and what we are paying out. There are the strategies on how to get there, and we are looking at result-based financing or an output-based financing model. And to be able to get there, there are those things that we need to do. There is the amendment of the Health Act to recognize the different stakeholders. There is the several amendments to the NHIF Act. There is the PFM Act, which is specifically relevant to county hospitals, and also the contracts that we are having with the different providers. So this is what has been suggested in the different reform forums. We've interrogated the HEFREP report. It was an expert panel that was constituted by the ministry and looked at the way forward for the fund. We also have internal and external actuarists who've given their feedback, and we've run different data sets internally to see where we are as far as the different indicators are concerned. So the report outlined 55 recommendations, and these are what the fund is doing towards becoming a strategic purchaser of the healthcare services. As I've mentioned, there are those ones which we're in the process of implementing, and there are those ones which have been planned. And key to your part is on the provider management role. And with this, we are intending to have comprehensive amendments, not just to the Act, but also the way strategic purchasing of healthcare services is done. So as a private sector, I will start with a quote. This is from a USAID-funded project. It's called the SHOPS project. You know, a good number of times, those of us who've engaged with the donor community, you have to quote the donor reference when you're coming up with a quotation from their report. So that is the donor reference. And that is the grant number specifically. So it did not come from me. But from this report, they've indicated that the choice or the voice of the provider, that is the private providers, are often left out in the decision-making processes. And there is no systemic way for them to make their viewpoints known or channel them to policymakers, especially when they are voiceless. So strengthening the voice of these providers means giving them an avenue to make their thoughts known and to facilitate communication. And I would like to believe that is what we are meant to achieve out of this. So there is what has been proposed as far as the engagement with the private sector is concerned. And if you look at the reports that are available globally, they actually recommend having associations who have a similar goal to articulate for some of the issues that are being brought up by different players in the private sector. So what they are meant to do is to solicit private sector inputs into the products, as I mentioned, the policies and the regulatory processes, have an inbuilt system or way of promoting quality or training providers in the different new best practices. There is what we are doing as a fund, especially as it comes to overseas treatment. There has been a concern over a period of time, why are these patients not being managed locally? So there is a concept that we have and is meant to help improve the local capacity in terms of these new technologies and also management of complicated cases. There's the contracting and empanelment of private providers in public health insurance programs, which we are doing and we are hoping to strengthen. And then there's this information that we have. We really have to guard the information that we have. We need to make it accurate and we need to make it real time. I think that is one of the gaps that we have and we need to work towards that. And then of course, we ask you to implement some sort of supportive supervision to your members. I think Douglas can mention here that some of the things that we see out there are not very encouraging. So when this member comes in and they say they are a member of Rupha, and somebody is sent to do an independent assessment of the facility, and you look at the report, you really get discouraged. So at some point, I think I mentioned it to Dr. Lishenga that our target should not be the payments. Also look at the quality of the services that these members are offering. Let Rupha be some sort of brand so that if a facility has that logo of Rupha, there's that quality of care that is associated with that logo. And that is what we are hoping that a supportive supervision framework that is rolled out within the association should be able to weed out these guys who are ruining your name. Let me just put it bluntly. So we've looked at different forums. We've looked at what has been presented in different forums. And this is how we are intending to engage the private providers. One, we've categorized them into the different providers. There are those ones who are payers of financials. For example, commercial insurance, the commercial insurance sector. In as much as some people see it as a competitor, it is actually an important stakeholder if we are to achieve UHC because they have a role to play. And I would probably refer you to the congressional report on Medicare and Medicaid. It was published in March 2018. And it gives some details about Obamacare and how it has worked and the interaction between Obamacare and the commercial insurers in the US. That is our first level of engagement. The other engagement that we have is with the different providers. At the moment, our engagement is with private hospitals and clinics. We are hoping to get to a point where we'll have a direct engagement with the different specialists in the different fields. And there are several suggestions in which this has been made or this has been requested so that we can be able to achieve that. The civil society organizations and the charities also have a role to play. A good number of the vulnerable population is actually sponsored by this. And also when we look at the GIS data in the country, because we've mapped out the different facilities, more than 6,800 of them. We've done the GIS mapping and we've linked them to the services that we are offering. You'd realize that most specialized services are actually offered in urban or peri-urban areas. So what do we do about these other areas? What do we do about the rest of the country? And to be specific, about 83% of the specialized services are offered in urban or peri-urban areas. So as Rupha, you have a role to play in improving access to the specialized services in the rural areas. Then suppliers. We have a concept that has been done about the pharmacy and the medical devices benefits. And it's meant to address the interaction that we have with different players who are suppliers in terms of the medicines and in terms of the medical equipment. I'll not be able to give the details for that at the moment, so don't quote me. But there's something that is meant to address the gaps that we are seeing as far as those two are concerned, the medicines and the devices. So there's what we expect as the output from the engagements that we are having with you. One and most important is the quality of the services and the products that we are buying from you. And this should be considering the whole population, be they the poor, be they the marginalized populations, make them affordable, make them accessible, and make them sustainable. The next bit is the UHC principles. The private sector has a big role to play, as we've seen, and we are looking at leaving no individual behind. We are looking at you developing business models that actually appreciate the UHC concept and how you can play a role in actually bridging the gaps that we have as far as achieving UHC is concerned. We are looking at you aligning and testing your business models to the UHC goals. At the moment, the ministry has published some of the targets that are intended. We also putting out some information to the public on what we are intending to achieve as far as UHC is concerned. We request you look at these goals and see how you can innovate or realign your business models towards these goals. And then there are those innovations that we have to come up with. There's the value-based financing. We have to get value for the monies that we are paying. And if this value is being gotten from the private sector, then we have to engage you for these services. There's the payment for performance. I had mentioned that earlier. If an investor is making access to the services or the outcomes of the services being better, then we need to recognize them as a payer. And that is the payment for performance model. There's the result-based financing of healthcare services, and there's the strategic procurement of healthcare services. Then we appreciate the role that you're playing in strengthening the health workforce. I think it has been a challenge, and as I don't know whether there are members of KMPDU here, you will probably be able to articulate this better. It has been a challenge, retaining a good healthcare workforce and making a good use of them. So as a pair, there are those things which we have proposed. An example is the specialized services. We find it a bit wasteful to have an interventional cardiologist who does 10 procedures in a year. It would be better to contract a particular service to a particular provider and then push the members to go there. Not only does it build us in terms of achieving the economies of scale, it also builds the technical capacity that is available there on the ground, because you're able to see more cases and you're able to get better value out of the skills that you have as a doctor. Then there's the efforts that we have to do to contribute towards financing for UHC. I've mentioned the major pool that we have is contribution from the members. But then we are aware of a good number of instances where this contribution is actually curtailed by the providers. They induce the members to actually not to contribute, what we are calling adverse selection. A member comes in, they access a service worth maybe 80,000, their total contribution is about 6,000, and then they exit. At the end of the day, it limits our ability to expand our scope in terms of the services that are being offered, or in terms of the kind of engagements that we can have because of the limited resources. So we request you to play a role in terms of enhancing these contributions. And then finally, there's the dialogue bit towards policies and towards partnerships with government and other stakeholders. I think we should not be running parallel systems. It should be one informing the other, one building the other. And we are hoping that by that kind of an engagement, we'll have a more fruitful engagement. And what we are targeting as a collaboration between Rupha and the fund should be able to be achieved through these kinds of outputs. Thank you.
Let's give a proper round of applause for Dr. Kora. Daktari and Mr. Douglas Owino, I think we want to thank you so much. Just listening to Dr. Kuhora, you notice he sounds like an academic. Did anybody get that feeling? Like he sound very professorial. Dr. Kuhora, that was an excellent presentation. I think you've captured a lot of the sentiments. I hope that colleagues, you have picked up a lot of points from what Daktari has presented. I think there is a lot of content in what you presented as far as how NHIF is thinking about this. And you also get a sense of the general policy direction around healthcare from the government side. And I am hoping that, because I think we don't get such opportunities very often. A lot of us have been asking how we are going to play a role in UHC, what is going to happen. I mean, we have to accept the reality of UHC is here with us to stay. Now, how are we going to play a role? And I think your presentation, Daktari, really sheds a lot of light. And once we get into the panel discussions, I am looking forward to questions that are very incisive, go to the core of the matter. Ask yourself, when Daktari says you need to develop business models that match UHC, what is that business model? You don't want to miss the train. When my brother Douglas Owino was talking about contracting and the fact that make sure next year when we come, all the services you want are there. Ask yourself, let us ask ourselves, what does this mean? What is the impact? What is this going to be to us? Because I know the new contracting cycle is coming up, okay? And we are always discussing amongst ourselves very healthy addendums. What, I mean, you've heard it. What he is saying is that as a corporation, a state corporation, they have real problems processing addendums. Maybe it's a policy issue. But now we as an association, as hospital owners, this is a real challenge for us. Let us ask ourselves and let's think about these things even as we prepare for the plenary session. It is my honor now to invite our next speaker. I think she might not. Sorry about that. Our next guest doesn't need any introduction to those of us who are with us last year. Dr. Elizabeth Gitau, CEO of the Kenya Medical Association. She is here to represent the president of the association, Dr. Were Onyino. I think, colleagues, you will agree that part of the reason why we like to invite KMA is that, unless I am wrong, KMA actually sits on the NHIF board, isn't it? Yes. So, I mean, and some of us here are actually members of KMA by nature of our profession. So we feel that KMA is an excellent partner for us every year. Dr. Elizabeth Gitau delivered a very rousing speech last year. We don't want you to do the same, but we will not mind. Karibu sana, Daktari.
I'm so short. I hope you can see me. I think you should have put a step stool here. All right. I think you will hear me even if you don't see me. My name is Dr. Elizabeth. Most people, I think, call me Liz. I think my name tag is printed Liz. So I'm Dr. Liz Gitau, minor. I'm the CEO of Kenya Medical Association. I was ambushed to represent Dr. Were, who was supposed to make a presentation on behalf of KB regarding the Health Act of 2017. And more so because he has sat in the Kenya Medical Practitioners and Dentists Council and was part of the team which interacted with this bill before it became an act. But I'll go through the act possibly very briefly and save you a lot of time, and possibly the things that I will highlight, you'll be able maybe to now download the act because it's available online and look at what are the various rights and obligations that as an entrepreneur in the private health space. So before I do that, maybe with the passage, I'll probably maybe go through like what the Health Act, what it changed. With the Constitution of 2010, there were a lot of gaps between how the national and the county government interact with each other. And the Health Act of 2017 formalized the collaboration between now the national and county government, and also addressed the needs of the vulnerable groups and mandates the provision of emergency and specialized care. So when you look, even when you have financing for the vulnerable groups at NHIF, it is because you have a health act which actually now speaks to the Constitution of 2010, and also in terms of inserting the rights of health providers, inserting the rights of the patients within an act so that you're able to achieve what is factored in our Kenya Constitution. So I will probably just go step by step and maybe pretty much highlight the various things that will affect the private sector. So there are various sections within the Health Act of 2017, which directly speak to our practice. Myself as a healthcare provider, and also as an owner of a medical clinic, and even working again as a CEO of Kenya Medical Association, working within advocacy, regulation, and also self-regulation of our members. Number one, maybe we'll talk about the rights and duties. And these are the rights of patients. When you look at Article 46 of our Constitution, it says that everyone has the right to access health. So in now in part 2, section 6 of the Constitution of now the Health Act gives now more elaborate in terms of what are the rights to patients, and speaks about the right to reproductive health, which has probably was not elaborated in the Constitution, but here it is elaborated, means that everyone of adults has a right to access reproductive health services, and you as a provider or as a clinic owner, you have an obligation to ensure that this right has been achieved by ensuring that all your patients, as long as they've given you informed consent, that they have a right to access all reproductive health information services, and including family planning services. Number 2, I think, which has brought a lot of, I think, sensation within the media, has been regarding emergency treatment. So everyone has a right to emergency treatment, and you as a provider, or you as a hospital, you must institute measures within your hospital to ensure that if I come in today and I'm in an emergency, I am taken care of, whether I can pay or I cannot. And what is emergency care? Emergency care means pre-hospital treatment. So in case somebody, maybe an ambulance finds me at the roadside, it is a responsibility that they need to take me to hospital. Number 2, stabilization of the patient. So if a patient comes in, either it's an RTA or bleeding, so you need to stabilize that patient. And once you stabilize the patient, number 3, very key, and that is where most of us fail, referral. So sometimes you stabilize and you tell the family, sasa musonge mbele. There you have not correctly referred the patient, because a referral means that you're telling them where to go. You're providing the ways on how to go. Failure to do so, you have an obligation, you're liable to up to a fine of up to 3 million. And should it result in a death, of course, you can actually be sued in a criminal case or in a civil suit by the family. So I think in terms of emergency treatment, that is what would be our obligation. Maybe you can, in terms of informing staff, I think maybe most of us know, but maybe our staff do not know. They will keep asking me, where is your card? Where is your money? Put a deposit. But before they do so, they ensure that the patient is actually not dying. The other section that affects us is informed consent. That is what we'll land you in KMPDC in terms of informed consent. So patient comes in, maybe like, especially I think most of it is maternity based, where a patient now maybe wants to have a C-section or maybe surgery, because patients will come and say, hata sikuwa nataka hiyo surgery. maybe you're removing small things like a lipoma, sikuwa nataka, and it complicates. I did want, I was not told, and maybe you in your hurry, you did not sign any forms. So there's a provision that you must get informed consent, and informed consent means that you have talked to the patient, they have understood the procedures, they have understood the risk of the procedure, and they have understood the benefit, and preferably let them sign a consent which you can file so that it is not verbal. So there are also provisions where you can go without informed consent, and this is where it's an emergency. So if I'm having a cardiac arrest, you really don't need to ask me whether you should resuscitate me. So those are, or if a mother is bleeding. So if you feel, or if I have COVID, or if I have maybe tuberculosis, you've seen people being arrested for TB. That one you don't wait for informed consent because it's of public health emergency. So those are some of the areas. Or if somebody who's mandated to give consent is able to give consent. So those are some of the areas. It has various provision, about 5, where you can proceed without informed consent. So in terms of documentation, that is where we get it wrong as most providers. We do not document this consent. And when you come to the board, that is where we start stammering. The other section that I think I'll go to is in terms of right of healthcare providers. So as employers, most of us are employers here, is that healthcare providers also have rights, similar way to patients' rights. And number one is, of course, not to be discriminated against based on how the Constitution defines discrimination. So you don't not hire me because I am pregnant. You don't not hire me because I am disabled by any chance. So I think those various ways in terms of if I go to court and I say to you, I lost my job because I got pregnant by month 3 and you didn't sign my contract, that also puts you in a difficult position. Number 2, right to a safe working environment, and public health is good at this, ensuring there's ventilation, ensuring there are you have ramps and all. So the environment needs to be safe to work. And that is where WIBA comes in. So in terms of labor issues, ensure that maybe you have read the WIBA Act and are adhering to it so that you know what's a safe working environment and how do you ensure your staff is protected. The other thing about healthcare provider, a healthcare provider has a right to refuse to treat a patient in cases where the patient is either physically abusive or verbally abusive or sexually abusive. But in case of emergency, they must treat the patient if there is no other alternative. So if you have a right to actually say you will not see a patient. And also they have a right to work either in the private sector or in the public sector as may be available to them. So in terms of rights and duties, those are part of what would affect us as Rupha members or what would affect you as a clinic owner. The other part of the Act will speak regarding what the Ministry of Health is supposed to do in terms of the public facilities and in terms of establishment of a Kenya Health Human Resource and Advisory Council, which I think maybe Ministry of Health will tell us maybe how far that's gone. There's establishment of KH Power. So Kenya Health Professional Oversight Authority, this has been established already, and I'm sure you have interacted with various staff from KH-POA. And KH-POA is supposed to be sort of an oversight authority to take in complaints from members of the public. They're supposed to ensure health professionals are adhering to their professional conduct. And they work with the various regulatory councils, that is the KMPDC, Nursing Council, Clinical Officers Council, to ensure that the standards of care are met within the country. So in terms of KH-POA, of course, it's work in progress regarding establishment of a board and a clear office and a clear mandate. So I think there, in terms of funding, so KH-POA is still, I would say, work in progress, but I think we have been interacting with them in terms of regulation and them being the sort of the final say in terms of whether we have met the requirements of serving the patients or not. So there's also another part in terms of regulation of health products and technologies. That one I'll not discuss. Promotion of public health. Where I want to go is what affects you in terms of the private sector participation. So this is a good act because for the first time, I think now we are recognizing the role of private sector within the healthcare space. And part of the, in terms of the private sector, what are your obligations even as you serve patients? So the Act allows that as a healthcare provider, you can establish a facility within the regulation by the various regulating councils, so the various levels by various health professionals. And once you have been given the license, you must facilitate inspections at whatever point the regulator would like to inspect. So nursing council wants to come, clinical officer, KMPDC, KHPOA, you must facilitate public health, you must facilitate inspection of a facility to ensure that you meet the criteria for serving the patients and you meet the basic requirements. The other thing, again, private sector, to repeat, you have an obligation to provide emergency services. So this is not an if or an or, and so that it does not land you in problem. The other part that has been provided in the Act is also public-private partnership. So this probably has not been seen before, and maybe NHIF is a good example, a bit of public-private partnership. But I think also now, can counties now give contracts to private sector to provide services? Yes. Within what framework? That is what is being worked on. So pretty much Kenya Healthcare Federation, where also Rupha is a member, has been working together with the Ministry of Health to establish the PPP framework for the health sector. And I think we are doing the validation over the last few weeks so that to see how can County of Nairobi, can they give me a contract to provide laboratory services for their members and they pay for those services as a county? Or can a county say, we do not have cardiology services and those ones are contracted to XYZ? So generating those frameworks within which the public and the private partnership can work, which will improve the quality of health and enable us to achieve UHC, because UHC is not a public sector issue. It is a health issue for all Kenyans. So, and that is why the private sector should not be left behind when we are doing UHC efforts within the country. I think most of it has been focused on the private sector, but we also, public sector, sorry, but in terms of the pilot. But I think moving forward, we need to enable the PPP so that we can ensure that all Kenyans have access to UHC. So the other part, as I finalize, I usually do not speak for long, is regarding e-health. So that is what COVID times has taught us. I'm seeing more virtual meetings, and there are many providers, and they will possibly be members of Rupha if they're not, who provide telemedicine, or you within your facility, you want to improve access to your members and you want to ensure that you're able to serve. So this Act enables this formulation of the licensing and the regulation of e-health, so that we are telling you, for you to establish and for you to be able to see patients online, this is what you need, and these are the obligation of you as a provider, and what does the patient needs to do, because most of our work as clinicians is mostly see, touch. So in this case, you're not touching the patients, you're only seeing the patient. How does that ensure that you're legally protected in cases where you're not able to fully examine a patient? So those regulations are there, and I'm sure KMPDC is working to get a gazettement of the telemedicine regulations that they have set up. I am not sure whether they have been gazetted yet, so that you'll be able to get a license for you to run telemedicine services. The other thing possibly is also in terms of e-health is in terms of data. So the national government, and I'm sure through the Ministry of Health, has been tasked to ensure that they develop an integrated health information system within the country, which is able to combine data and also interconnect data within the public sector and the private sector, whereas ensuring that there is data safety in terms of protecting the patients, and also in terms of utilizing this data also to inform the health priorities of the country. So within e-health, of course, there's a lot to be done so that both it is acceptable to us as providers and also acceptable to the patients as well. So maybe to finish this very short presentation. It would have been longer if I was the invited guest. Anyway, so maybe to finish is that I think as providers, especially while interacting with patients, while interacting with employees, to ensure that we are conversant with the various provision of the laws. So make sure you, within your setup, the Health Act is available, the Labor Relations Act is available, and so that when you're dealing with either your staff or your patients, you know your rights as a person and you know your obligations as a healthcare provider, so that all of us can be able to enjoy right to health. Thank you very much and have a good day.
Thank you very much, Dr. Elizabeth Gitau. Let's give her a better round of applause. I've decided to walk around a bit because with that mic you can't see what's going on. This place is dark. But anyway, good morning, ladies and gentlemen. Good morning. Apana, can we all stand up? We are tired or we are hungry or both. We can stretch a bit so that we are ready to listen to the, yes, thank you very much. There's a bit of light. We can stretch. Okay, very well. Thank you. Okay, we can be seated. Thank you. So my name is Dr. Njoki Fernandez, and my name is Dr. Njoki Fernandez, and I'm a healthcare consultant, and I'm here to introduce my next guest. But before I do that, as a friend of Rupha, I find it important to highlight some of the things that have been said so far that resonate so much with the work that I do. I'm a friend of Rupha. We met last year. Then I was working at Minet, which I have since left. And so what we do now is we are a company that deals with healthcare strategy and consulting. And some of the things that have been said today are exactly, I was thinking someone has been reading my mind. Because Dr. Lishenga said at the beginning, for Rupha members, this is our time. This is the time for us to arise and shine. And Rupha hospitals play a very, very big role in the provision of healthcare in this country. We really supplement government efforts in trying to provide healthcare, especially in the rural areas. So we need to own our space and not feel apologetic about who we are and what we do. Yeah, we must arise. We must arise and own our space. My friend Douglas, I met him in Mombasa. How are you? He talked about strategy. And that is a very good thing we need to think about. What is our plan moving forward as healthcare institutions, as an individual business? Because we are private businesses, isn't it? We're private investments. People have put in money to provide a health service, but it's also a business. So what is the plan moving forward for each of us? We must think. 2020 has been a very tough year. And even if we're alive, we're not sure we'll even manage to run our business into 2021. So this is a time we need to be examining ourselves and thinking, really, what can we do to make a difference? The role that we are playing in UHC, Dr. Kuhora talked about it, very important. We are key, very key to the provision of universal health coverage. So we have to have a business that is oriented towards universal health coverage. How is that business model? It's something that we need to think about. And then, what is our financial model going forward as hospitals? It cannot be business as usual. It cannot be how it has always been. Is your main financier NHIF? For many of us, that is the case. And whereas NHIF, they take a big chunk of our business, it is true, if there is a delay or if there is a hitch, then what happens? Does your business collapse because you do not have funding? Yeah. So what are you thinking to do to make sure one supplier? How do we collaborate with each other? That's something that has been mentioned again and again and again. What we do as institutions sometimes is we tend to be very thinking in silos. I want a cardiologist in my hospital. Another wants a cardiologist in their hospital. So you want 3 cardiologists and your radius is 10 kilometers. It doesn't make sense. Yeah, because you cannot put up 3 cardiology centers in the rural areas in a radius of 10 kilometers. Why don't we collaborate? We say hospital X, we will channel all the cardiology patients to them. Hospital Y, we will put together all the renal patients. And hospital Z, we will support them to buy an MRI machine. Yeah, then we split, we share the risk and we share the benefits. Yeah, this is something we need to think about. Let us work together. And I'm sure many of us are in the same area. Let us start this conversation. How do we maximize on our medical personnel? You cannot have a surgeon or, like he said, an interventional cardiologist who does 10 procedures a year and he's on full-time salary. That makes sense. Yeah, but he can do interventional cardiology every day in 5 different facilities. Yeah, your patients benefit, the doctor earns some money, and everyone is happy. Not everyone can buy an MRI machine, but we need an MRI machine in the area. So how do we come together and tunnel our patients in that direction? How do we manage fraud? How do we manage the leaks that we have in our systems? Yeah, because we lose a lot of money that we don't need to lose. How do we price our products? Are we competitive? Or are we woye? You know, you feel woye the patient cannot afford. That's why your bed charges 500 bob a day. It can't be. 500 bob cannot sustain you. So these are the tough conversations that we, in our team, help you have and help you decide and reorganize your team. So we'll be very happy to engage moving forward and help you so that next year is the year of Rupha. Ama namna gani? Very good. So I'm very happy to introduce our next speaker today, Dr. Simon Kibias. Simon is a public health specialist. I've known him for many years. When he was he was a head of emergency and disaster management. We were hosting the Pope. Do you remember? And then now he's gone on to become the head of Directorate of Health Standards, Quality Assurance and Regulation at the Ministry of Health. He's here on behalf of the CAS, Mercy Mwangangi, and he's going to talk to us and then officially open the convention. Welcome, Daktari.
Thank you. Thank you so much, Dr. Joki Fernandez. Yeah, I'd like to recognize the chairman, Rupha, Dr. Lishenga, the other guests who are here, the Clara Kimtai, Secretary General. I understand she's still on her way. Dr. Kihura, representing Dr. Bita Kamunyo of NHIF, Dr. Onyino, no, Dr. Were Onyino, KMA President. We have also Muiruri, Smart, and the rest of invited guests. Good morning once again. Well, I'm here more specifically to represent our Chief Administrative Secretary, Ministry of Health, Dr. Mercy Mwangangi. She is engaged in other businesses of the ministry, very critical indeed at this time. She's invited to the National Assembly. You've heard from Dr. Lishenga that right about now, we have issues within the health sector that needs to be addressed. So she's there. I'm sure she would have loved to be here, to share with you thoughts about how to improve access to the healthcare in our country. I have a message, but before that, I'll take 1 or 2 minutes to say what I do, because this I don't get this chance all the time, right? Brian Lishenga said that I'm active in the social media, right? Yeah. Yeah, like anybody else, I get worried about the infodemics. We have a pandemic now, but we also have infodemics. Wrong information, misleading, and so on. So I also look around. And when I get a chance, I also throw in 1 or 2 words there. So I don't stop, I know as a public health specialist, I know there's so many ways of influencing policy, and one of them is communicating. So you communicate your feelings. Well, notwithstanding having worked in the disaster risk management, where we must have met with Dr. Fernandez. Where I am now at the Directorate of Health Standard Quality Assurance and Regulation, I still also support disaster coordination, right? And it was mentioned just a short while ago about emergency medical care as a right. Every citizen has a right to access to emergency treatment, the stabilization, at least before referral to a definitive care center. We have a policy, emergency medical care policy, to address that bit part of the Health Act. And as we speak, I think it is still to be presented in the National Assembly for discussion, and possibly a bill will be done to that effect to address, so that we legislate emergency medical treatment. You see, the critical issue is for us to get an emergency medical fund set aside by the ministry. Already the Parliament has passed a resolution that we should set aside an emergency medical fund. But as we speak, we still have situations whereby hospitals are unable to take in an emergency case, and they're asking for money fast. Yeah, that has landed some hospitals in trouble already. And then what we have not seen happening is our colleagues being taken to KMBDC or even courts of law to answer to not responding to an emergency treatment. So we are working very hard on our part to ensure that that emergency medical care policy is taken through the motions of becoming approved and then legislated, so that we, all of us, are well informed about how to provide that emergency medical treatment. On standards and quality care, you know, it's very easy to talk about quality, but to provide a quality care, it's not easy. It takes a lot of inputs, and I'll just single out only one: the availability of human resource. We work closely with KH4, as was mentioned to you, and all the regulatory bodies, be it from all the cadres that have regulatory bodies, Nursing Council of Kenya, Clinical Council, Kenya Medical Practitioner Dentist Council, and the rest, in ensuring that we administer the joint health inspection to health facilities, and also make sure that we implement the Kenya Quality Model for Health, which I'm happy to mention to you that now we have already mentored 5 hospitals, in the, level 5 hospitals, on electronic Kenya Quality Model for Health. Yeah, sio ni afadhali kidogo, at least moving away from the manual books, the manual. We would like to see a future whereby you, as a provider, even in a private facility, you administer the self-assessment of the KQMH ahead of the inspectors coming, so that you can already see what the gaps you have. So the most single challenge to quality of healthcare is availability of healthcare providers. Generally, Kenya, we are doing like between 10 and 13 healthcare workers per 10,000 population. So that's a very serious gap. In fact, when we were trying to argue our case in PBI, the committee were quick to point out that, well, oh, you are from the health sector. Look, the education sector has already attained the UN recommended workforce per population ratio. The disciplined forces have also attained their target of the disciplined forces per population ratio in our country. It's only in the health sector that we have not. Our target is 23 healthcare workers per 10,000 population. So I think we are obliged, both the private and the public, to try and adhere to the norms and standard for human resource. As we were talking with Mururi here, I showed him the norms and standards 2014, 2018. It's available online. But it's a tall order. When we come to you, some of you would probably even marshal some people on a short contract when you are anticipating an inspection. And then you position the health workers. Then after the exercise, you possibly send them away. Yeah. So it's the most most difficult part of ensuring that the quality of healthcare is provided. You know I don't know why we believe that possibly, say, let's take an example of obstetrician. Is it gynecologist or obstetrician who does the cesarean section? Who does the Caesar? Gynecologist. So you as a CEO would like to ask the gynecologist, I want you to do 10 Caesars per day as a measure of performance. But you don't look at the quality. Eh? We need to be doing workload analysis to establish what is the optimum number of Caesars, for example, for that, using that one person can do a day, so that you produce quality service. Yeah, if you are doing 20 per day, then you need 2 gynecologists. It goes without saying, if you don't make a reference to the norms and standards, isn't it? So, and so on and so on. So just to sum it up, in the recent past, we conducted technical assistance with the support from Kenya Medical Professional Dentists Council, provided a TA to the counties in the face of this pandemic, to look at progress made in, and also see. So there was a whole section of human resource for health, and there the checklist was looking at how compliant the facilities within the counties were on the norms and standards for HRH. The overall, the sample size about 1,800 facilities was 30%. Yeah, you can imagine. So that is what we do. I wanted to impress to you that we are doing something. Yeah. So in 2018, 2019, our team, working with the regulatory bodies, and KHRAC is also active. KHBOY is headed by the CEO, is Dr. Jackson Kioko, the former DMS, and KHRAC, Kenya Human Resource Advisory Council, is headed by Dr. Wamai, and also that's a lot of work in progress. So in the implementation of the Health Act 2017, yeah. So in the pursuit of implementation of Health Act to support Dr. Kitau of KMA, the ministry established a national committee headed by our Secretary of Administration, very senior position officer, with 12 technical working groups with various work streams. One of them is service delivery. And it's looking at all the sections of that Health Act, all the parts, including the chapters, what do you call the other side? The whole section, and look at all the bills that are being developed to address to implement the Health Act 2017. So we are working very hard to implement the Health Act, and that falls under my directorate as well. So we are trying to do, and as I was saying, in 2018-19, we inspected the aim was to inspect all health facilities in the country, public and private, and we closed quite a number, over 1,000. Public and private. And we had some facilities. But we said that was an opportunity. Some facilities you must have seen in the papers. I had a dispensary with one staff who appears once in a week, in a month. That one was closed by the teams, you know? And then our response to the CECs was, use that report to ask for more funding and more staff from the governor, isn't it? So we inspected, downgraded quite a number, closed some, and confirmed a good number. We are doing our best as a directorate. So I think, so it's my pleasure to be with you here today. And I thank the CS for allowing me to come, so that we just say, we are not just not there, we are just not sitting there. We are doing something to address the quality of healthcare provision in our country. So it's now my duty and a pleasure to read out the message from the Chief Administrative Secretary. So I'll summarize it by, since I've already called out to you, all protocols observed. Good morning and warm welcome all of you attending this second annual general meeting of the Rural Private Hospitals Association of Kenya. The goal of universal health coverage is to ensure that all people obtain the health services they need without suffering financial hardship when paying for them. A robust and integrated health sector with strong governance is essential in ensuring accessible, affordable, and quality healthcare, one of the most fundamental human rights. The government of Kenya adopted universal health coverage as one of the big four priority agenda, with an aspiration that by 2022, all citizens will have access to quality healthcare services that they need without getting into financial hardships. This move resonates with the country's 2010 constitution, which provides an overarching legal framework for this rights-based approach to health. The Ministry of Health and the entire health sector aims to achieve this goal through supporting provision of equitable, affordable, and quality health and related services at the highest attainable standards to all Kenyans. Further, UHC improves or maintains health through needed services for individual and populations. Access to and use of health services enables people to be more productive and active contributors to their families, communities, and society at large. While health may be conceived as a public good and a basic human right, its provision is currently not exclusively delivered by government. It is becoming increasingly important to involve the private sector to supplement and reinforce the services of the public sector. The private sector's involvement in health systems is significant in scale and scope. Private sector involvement in the provision of healthcare encompasses a complex range of activities. It is important to address private health hospitals and organizations involved in light of the aim to achieve UHC. For example, private actors may not always have the incentives to deal with externalities that affect the availability, accessibility, acceptability, and quality of healthcare services. They may not be in a position to provide public goods, or they may operate under imperfect information. They may also offer services as part of primary care network, offering services that are needed within the network but not available at a public health facility. The government of Kenya, therefore, plans to roll out the national scale of UHC through an output-based mechanism. The UHC scheme administers through NHIF. This will allow Kenyans to select facilities of their choice, thereby improving access and quality of care. The ministry also aims to achieve UHC through the primary healthcare approach. Primary healthcare will change the focus from traditional reactive curative medicine towards proactive community centers, preventive and promotive healthcare. This requires a population-based low-cost systems that encourage people to manage their own health. The government will survey mechanism for partnering with private sector with the aim of achieving UHC to include capacity building, research, and peer-to-peer facility teams. Further, the private health facilities are challenged to shift their business models and prevent diseases. Thank you for your continued support and collaboration. I think that's the end of the message from our CAS, and I think that sums up. So I will end. I don't wish to say anything more beyond that, and maybe in the panel I'll get a chance to respond to some questions, fruitful deliberations during your convention. Thank you.
All right, Dr. Kibiasi is supposed to say, I officially open.
I still have another duty. Thank you so much, Dr. Brian Lishenga. Yeah, opportunities keep coming. So I think this is a rare opportunity for me to stand before a multitude of professionals, and I really respect that. I think we need to break the ice, to break the barrier between those working within government and those in private. I think we all belong to the same community. If I had the time, then I would explain to you all what we are trying to do. I don't think we are now statics. You can, from the look of things, you saw that those from the private sector, you really understand more what we do nowadays. It's because there's nothing to hide. There is a Consumer Protection Act and ensures that we share the information, be it whether it's our SACAs or ministry departments. We, like for example, in this pandemic, we have shared the guidelines that we developed, all of us, on our website. And you will see our evidence of our work there, and we share it. So it's once more my pleasure to, on behalf of our Chief Administrative Secretary, to declare this second convention of Rupha officially opened. Thank you.
Thank you very much, Daktari. That was a wonderful word from, and I believe we have taken our notes. Without much, just want to open this session for some plenary. From our speakers that have been there from NHIF, MOH, and KMA, would want, in case you have a question, you have something, a clarification you want them to make. This is the opportunity. We have like 30 minutes. Yeah, 25 to 30 minutes. Solve by name, a facility, and the county that you come from, and then you shoot your question. Would want us to be very brief so that we can have met. So I will pick the first one. I'll pick the first one in case you have any. Okay, Daktari here. Okay, thank you. Karibu Daktari. Excuse me, if that's not on.
Sorry. The invited guests, my dear colleagues, investors, good morning. My names are George Makori from Buxton Hospital, Mombasa, and I think I take this opportunity to of Rupha, and mine is to ask or to request NHIF, Daktari, we come from the rural place. We have decided to take the little money that we have to invest in providing healthcare to patients. And to be honest, most of us, the investments or the money that we have is gotten from the little savings that we have done. Not that we are big investors, but we have a vision. We want to go far. We want to invest. And essentially, Rupha, the biggest client is NHIF. So we depend on you. The support that you give us goes way far to support these investors here. So you find that your clients are served by us. The quality that we provide, if it's good, that gives a good name to NHIF. If it's poor, it will really mean that NHIF is not doing a good work. So we are trying to see a way that we'll have a good collaboration between Rupha and NHIF. We have some limitations. Limitations is actually financing. We tried to go to the banks and we realized that the banks kind of are not able to finance us as we want. We are asked for guarantees, which we don't have. I don't know if we could look for a way that NHIF, since we are doing this business every month, we're getting maybe 500,000, 1 million, maybe 10 million, or whatever the amount that we get from you. If we could have a collaboration between NHIF and Rupha members in a way that you can act as a guarantor to the people who provide things like machines, medicines, and whatever we need, so that you stand in as guarantee, kind of. If, for example, I'm in Kwale, Lunga, I want a scan to provide maternity obstetrical scan to a patient, which will tell me when we have fetal distress, and it's an NHIF patient, but I cannot afford at that moment to raise 2 million, but I'm sure within 2, 3, 4, 5 months, I'm going to get 2 million from your organization. If kind of we have a collaboration that these suppliers of machines can have a guarantee that this is our member or is a business partner with us, and even if you give this machine, there's a way you are guaranteed that your money will be paid by whichever way, either through the bank or through whatever, but he's actually our member and he's able to pay through the statement that we can provide.
Thank you, Dr. I think your
Thank you.
point is home.
Thank you.
Yes. Let me pick also another one so that we can have several. There's one hand at the back there. I think we had two microphones. We can have them concurrently. At the back, please.
Thank you so much. Good afternoon, everyone. My name is Eugene Musungu from Sterling Medical Center, Busia County. Mine is a question to Dr. Sam on the issues about contracts for facilities. We have a situation where over the last couple of months, I think almost heading to 2 years, facilities have had challenges in getting their contracts completed from the office, that's NHIF office. We are headed into a moment in mid-2021 where most of us, our contracts will have come to an end. I heard from what he shared with us that there'll be, first of all, reinspection of all the facilities to see whether we are meeting the standards. And one of the requirements would also be that we have our strategic plans in place. My question then is, what are the measures then that are going to be put in place so that we don't have a disruption of service provision? Because if we have taken such a long time to be able to accredit new facilities and the contracts end mid of next year, and then we take a similar duration of time, it means that the already contracted facilities as of now will have a gap of about a similar duration of time before they can be able to continue serving the clients. And this might also bring a lot of challenges. So probably you can comment on that.
Thank you. Any other? Maybe we pick, okay. More questions here. Please, let me have another microphone in the front. Okay, somebody there? Yeah, please go on.
Morning.
Morning.
I think I have a
It's
concern.
afternoon already.
Oh, it's already afternoon, sorry.
Thank you.
I have a concern that I will want to address to our colleagues from the MOH. Mine is about registration and licensing of private medical facilities. I have a feeling that we are totally being double taxed and the government is making it very difficult for us to operate our facilities. The year is coming to an end, and I know now we are expected to renew our licenses. You are expected to have a license from KMPDU, radiology, from the lab, from pharmacy, it's all over. Now that all these are government bodies, why don't the ministry just coalesce them in one so that we are just told pay 100,000 if you are level 4, level 3, and then having lab charging their side, and I think it's too much. Please make the work easy for us so that we are able to at least do business.
Thank you so much. Thank you so much. Maybe we can do one last one and then we have them answered.
Good afternoon, everyone. Mine is just maybe a recommendation to NHIF.
Your name, please.
Sorry, my name is Grace. I'm from South Lake Medical Center, Nakuru County. Just an observation. Maybe there was a communication about retention, especially from the informal sector. Our bloodline, I'm going to confess, is NHIF. That's what we depend on. Because I operate in an area where we mostly deal with flower farm workers and they're seasonals and all that. But you find out it's like they do not understand the concept of NHIF. Yeah, maybe when someone comes to the hospital and is a walk-in and you find maybe it's someone who is not very much able to pay, they will ask, do you have NHIF? Have you chosen a facility? Then they would say, apana, hata mnanikata pesa mingi sana. It's like they don't know how NHIF works. So maybe in your strategy for the next phase, just put information to people so that they can know, because I know NHIF helps. Another one maybe is just a question I'm going to pose. there's this thing that is going around. I don't know whether I'll call it like infodemics, like what Dr. has said, that the accreditation of NHIF was moved from NHIF to MOH. Those things are flying around, and maybe that's why there's a delay in all those processes. Maybe just a clarification of that and what you expect. Thank you.
Thank you so much. Okay, my sister there, if you can take one and then they are answered first.
Yeah, thank you for that opportunity. My name is Naomi Kirui. I work for Centers for Community Health Access, and we are based in Nairobi in an informal setups of Ruaraka area, where we have a lot of informal setups. And I'm so grateful to be here, and I've heard a lot from our leaders here. I'm grateful also to Rupha because of this arrangement. My concern and question still is within the NHIF accreditation. Yeah, Rupha facilities are serving the I would call underprivileged population, and we hope to play a big role in the UHC. Our catchment area, to be particular, is we are serving clients that are low resource setups, and they cannot afford cash payments. So they are working within the industrial areas, and their only hope is NHIF. So we cannot run away from the fact that NHIF is where we rely to be able to serve these people. And unless we are able to serve these people, we cannot achieve UHC no matter what we do. So our facility was assessed for accreditation in 2019. This is the end of 2020. We are still waiting for accreditation. And Dr. just told us that there will be a reassessment in March. We don't know if we'll be accredited by that time, because looking at the time that we are in now, it's December 2020. The new contracts are in 2021. I know for those facilities that are expecting to be accredited, they have to be reassessed for, the contracts will end in 2021, mid-2021, then they are also reassessed for new contracts. So my question to Dr. is, for those facilities that are still awaiting for accreditation, is there a hope that the accreditation will come before mid-2021? And in case they get the accreditation, the assessment, will they be affected again?
Thank you
so much.
Thank you very much. Thank you. Let's take a pause there so that we get the answers from our panelists. Maybe we begin with NHIF. You can use that. You would want to come here, or you can use
Okay, thank you for your questions. I think the major issue is about accreditation. Let me put it in quotes, and I'll explain why. And the providers, the issue of empaneling the providers. First of all, what we've come to know as accreditation by NHIF is actually not accreditation. It's just an assessment as a prerequisite for purchasing of the services. Accreditation is done by a different body, and I think at the moment for healthcare providers, that is what KHPOA is doing. And within the legal aspect, there is KENAS which does that. So what we do as an organization is the purchasing of these healthcare services. And for us to be able to buy this service, we need to assess whether the provider meets the very basic minimums that we wish to have for this provider to do. Once we have that that assessment done and the criteria met, it is taken to the point of declaration, and that is the role of the board. So a good number of times, there are those of you who ask whether the board has sat. Now, the role of the board is to make an approval on these requests and to approve for declaration. Once that is done, the facilities are gazetted as per the NHIF Act, and it's a provision in Section 30 of the Act, and that is done by the AG's office. Now, as to why there have been a challenge and why it took a long time and what we are doing about it, that should be able to respond to what has been raised by Eugene and also the lady from Ruaraka. There had been a challenge because of the interchange on the aspect of accreditation, and it was required that the providers be cleared by a different government body, and Dr. Kebias has mentioned that. So when it came to the processes, we actually had to halt a number of the processes from October 2018 up till I would like to believe November 2019, when those provisions were made clear. And then the gazettement that came out, it came out on 4th of February 2020. So some of those applications that were made in late 2018 might have not been processed because of the internal or the processes that were needed for a body to do the accreditation, present the same for NHIF to do the declaration, which is within its mandate. So that is what would have caused some of the delays that we've been doing. But as I've mentioned, so far a number of requests have been provided, and 82 contracts are being prepared as at the moment, and we are expecting them to be dispatched probably before the end of this month for the providers who've met all the criteria. I will give my colleague an opportunity to probably give further briefs. Now, on the issue of collaboration with financing so that NHIF can act as a guarantor for HCPs to obtain credit, that would be a challenge because of our present model of operation. So in as much as we would wish to assist you in providing that, we are looking at a different way of doing it because it would be outside our mandate to actually do that as a financier. So what we are doing is to provide financial incentives for facilities who go an extra mile in having these services with them. And as I mentioned earlier, there are those facilities who've already adopted laparoscopically assisted hysterectomies. It reduces the cost burden to us, it improves on the outcomes, it improves on the clinical outcomes. So we are hoping to have a payment for performance model where we actually recognize or we appreciate or provide a financial incentives for facilities who go an extra mile to do this. But the direct payment, that might not be the case. And I mentioned something about the World Economic Forum. If you look at what happens in countries like Brazil, and it's documented in their presentation, a body like this is actually what guarantees their members. And I would like to believe JMA, the Japanese Medical Association, they actually do that. So when Rupha is strong enough, it can actually have a liaison with a bank or another financier, and this financier will be able to guarantee their members to do that. But within NHIF, that might not be possible. There's the issue of coalescing the annual charges. I think the ministry would be better placed to respond to that. Now, in terms of communication to the public, asked by Grace from Nakuru, we've improved the customer experience using the customer center, and we're able to show you the number of calls that we're handling every day. We've also improved interaction using online forums. We've had several webinars. Actually, between July and November, we were having monthly forums where individuals actually discuss with the public on several processes, and a number of these questions would be responded to. As far as how we are working to address the issues of the low-income earners, there has been a suggestion of having wallets so that this person can actually contribute 20 shillings every day or even 30 shillings every day. It is coalesced within an e-wallet, the way we do for Fuliza or any other phone-based forum. At the end of the month, this person will be able to have the 500 instead of expecting them to pay a one-off payment of 500. It would be heavy for some of them. So those are some of the ways in which we are exploring to address the challenges that are there with the low-income earners. Thank you.
Now, good afternoon. Good afternoon. Yes, first I want to clarify something before I respond to a few issues that you raised. For Eugene Musungu, Stanley Medical Center, when I made a remark on strategic planning, I didn't say it is a requirement. I was just advising ourselves to avoid maybe erratic situations whereby midway you want to do something you didn't plan for, but it is a best practice as owners of the businesses that you must plan ahead so that at least when you are coming, at least you put everything in place. I hope you have a strategic plan for your business. If you are running it without a plan, then I think that's dangerous. So we have to agree on that. It's not a requirement on us, but it's a best practice. So even at individual level, you need to have your plan ahead. Yes. So it's not a requirement. That's a clarity on that. So make sure that you have the necessary mandatory requirements ready, cage power, medical board, and all that. If your license is expiring, ensure it is valid. Because for us to bring you on board, we'll ensure that you have those requirements in place. There's been an issue, I think it is cost cutting. I know at one point, I even saw Rupha putting something in the media about the contracts delays. We acknowledge and you understand that there's some situation at one point when there's no lack of clarity, and now we are going to engage on that. But now there's proper clarity. And we are putting measures in place to eliminate these delays. And I want to assure you, that's why I wanted the contacts of the members here so that we engage frequently. And I'll open myself for, to be accountable on that aspect. Currently, we want to deploy a very simple online tracker so that you can track at any given stage where your contract or anything to do with assessments is, so that if it is delaying on my desk, you'll see that it's Douglas keeping my document. Are we together? We are going to deploy that. You know how the e-citizen platform is working, eh? And I know you have traveled, so you renew your passports. Nowadays, you don't have to ask or queue. You can always upload everything there. And you don't even have to go there if you don't have that token to go and take your photo, is it? And when you to collect. Of course, we want to have a system, very simple, that allows you to see where we are with your services, to allow for public participation, to allow for accountability and transparency. So we are going to do that very soon, hopefully. The issue of Grace Southlink Medical in terms of retention in the informal sector. I think what may be affecting you also in Naivasha, apart from retention issues, we have really been affected in terms of the flower industry. If we look at our system, we know most of them are closing down, so the numbers may be going down. But again, we are trying our best to recruit to ensure that they always convert by paying for themselves. So we are working towards that. But of course, again, we do conduct drives. We do conduct outreach programs. It may not be adequate. And that's why I'm saying that we have to look at us as partners so that you also pass the message when people come or when they don't have the card, so that they're aware about NHIF. So we work together on the same note. On Naomi, Center of Community Health, you said your contract has delayed, and I think I've explained that. And of course, we'll see how to work through it so that if it is a short notice, which is lying around, we are working overdrive to ensure that we dispatch them. So we can see
with the lift down, you just check out on the first floor. And I want to encourage, since we cannot fit in the lifts, all of us at a go, as some of us are going down 4 at a time in a lift, the rest of us can be visiting our exhibitors. They're also wonderful, wonderful people. We have ECOMED and ECL on that corner. And if you go through this other side, more exhibitors are there. Please visit them because they helped us to make this event successful. It will be good for you to be there and just see the things they're displaying. And we encourage you also to buy them, buy the products and services so that we can have them work very well with us even in the coming years. Lastly, but not least, I want to let you know that at the table at the back there, that's where the Rupha table is. And at the Rupha table, you will also get wonderful products that we have prepared for you. We have polo t-shirts. We also have round neck t-shirts. We have the water bottles. We have mugs. We have umbrellas. We have notebooks. And we have ourselves. Come and smile to us there. We'll be happy to meet you. Okay. So without much ado, I want to release us to the exhibitors, and for our lunch, we will be back here exactly at 2. So kindly be here exactly at 2. That is after lunch. There are a lot of serving points. You will not take much time there. So I want to declare that your lunch is blessed as you take it, that it will benefit you. Please pass through the exhibitors also as you go. I also want to ask the ExCom team if they can come here. I would like us to have one activity with them before we go for lunch. Thank you. Enjoy your sumptuous lunch and have a good time as you mingle together. Thank you.
Excuse me, just before we leave, we are issuing vouchers for lunch, so I would request that we remain seated so that the facilitation for the vouchers can be done. Kindly.
Dear members, kindly ensure you have your meal cards. They're called vouchers, sorry. Vouchers from our sister here, Pacifica. Yeah. Pacifica go at the end there so that as they go out, they pick a card from you. Thank you.
Okay, for the interest of time, kindly, for those remaining, I believe the elevators are empty at the moment. Let us take our vouchers and go have our lunch kindly.
Eunice, acha nipigwe ni kama Ati?
Okay, for the interest of
Ati niongee kwa mic, nipigie hapa address.
time kindly. For those remaining, I believe the elevators are empty at the moment. Let us take our vouchers and go have lunch. Elevators are empty at the moment.
My name is Dr. David Musita. I'm the treasurer for the root. My name is Dr. David Musita. I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national convention, which shall be held on the 10th and 11th of December 2020. Thank you.
Hi, my name is Dr. Brian Lishenga. I am the chairman of the...
My name is Ezekiah Omondi, CEO, Rural Private Hospital Association of Kenya, known as Rupha.
Hi, my name is Dr. Brian.
My name is Dr. David.
Hamjambo, majina yangu ni Joseph Kariuki, naibu wa mwenyekiti wa chama cha Rupha.
My name is Dr. David Musita. I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national convention, which shall be held on the 10th and 11th of December 2020. Thank you.
Kyle Mondi, CEO, Rural Private Hospital.
My name is Dr. David Musita.
known as Rupha.
I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national convention, which shall be held on the 10th and 11th of December 2020. Thank you.
I therefore welcome all of you to come and bring your ideas, share ideas, meet people, and let's see on ways we can make our health sector be a better place and provide better facilities.
Hamjambo, majina yangu ni Joseph Kariuki, naibu wa mwenyekiti wa chama cha Rupha. Nawakaribisha wote katika mkutano wetu wa mwaka tarehe 10 na tarehe 11 mwezi wa Disemba mwaka huu. Tutakuwa pale katika ukumbi wa Pride Center katika hoteli ya Pride Inn Westlands. Tunawakaribisha wote ili muweze kuja tuweze kujadiliana kuhusu vile private sector.
My name is Dr. David Musita. I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national conference.
Hospitals Association. The Rural Private Hospitals Association of Kenya is the largest hospital association in the country. We are representing.
Yes, that is good. So we'll leave and do a visit in the office. Hamjambo, majina yangu ni Joseph Kariuki, naibu wa mwenyekiti wa chama cha Rupha. Nawakaribisha wote katika mkutano wetu wa mwaka tarehe 10 na tarehe 11 mwezi wa Disemba mwaka huu. Tutakuwa pale katika ukumbi wa Pride Center katika hoteli ya Pride Inn Westlands. Tunawakaribisha wote ili muweze kuja tuweze kujadiliana kuhusu vile private sector inaweza kuhusika katika mpango wa serikali wa UHC. Karibuni wote.
My name is Dr. David Musita. I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national convention, which shall be held on the 10th and 11th of December 2020. Thank you.
Hi, my name is Dr. Brian Lishenga. I am the chairman of the Rural Private Hospitals Association. The Rural Private Hospitals Association of Kenya is the largest hospital association in the country. We are represented in 43 of the 47 counties, and we currently have over 190 hospitals who are members of the association. And I would like to very warmly welcome you to this year 2020 annual convention of the Rural Private Hospitals Association. We think 2020 has been a mixed bag. We have had a fair of successes, fair share. We have also had some difficult times. And I know that our members out there, hospital providers, can relate to this. Last year, when we had our first annual convention, we were just an association of 92 healthcare facilities. So we've grown by close to 100 members over the last 1 year. Last year, when we had our first annual convention, we were present in 27 counties. Right now, we are present in 43 counties. So we've had phenomenal growth. But at the same time, also, we understand that some of our members have had a very challenging year with the COVID-19 pandemic changing the health landscape. So we've probably seen patient numbers going down. Some of us have been personally affected by the pandemic, maybe losing a workmate, losing a relative. But as the year comes to a close, we are taking this opportunity to come together and take stock of what we've been able to achieve over the last year, and also plan how we move forward. So I am very excited about this year's annual convention. We will be focusing a lot on UHC. We don't want to miss out on that. More than that, as an association, this is the year when we get to launch our strategic plan. And this is something we don't want to miss out on. We want to look at our strategic plan for 2020, 2025, all the great plans that we have for the association. And we think that within the next 5 years, we should not only have the largest hospital association in Kenya, but probably the largest hospital association by membership in Africa. So we are looking forward to seeing you at this year's annual convention, which will be at Pride Center in Westlands, Nairobi, on the 10th and 11th of December. You don't want to miss out on this. We are going to have great discussions on universal healthcare. We are going to have discussions around the NHIF and reforms to the health system. But most importantly, this is the year when we get to launch our strategic plan for 2020 to 2025. So here is where we get to discuss all the great plans, all the things we see the association doing, the future of the association in the next 5 years, how we are able to capitalize on our numbers for economies of scale, how we are able to generate more influence within advocacy, be it in legislation, executive. So this is an exceptionally great time for you to join us. We know it's been a difficult year, but this is, we think, a great way for us to wind the year together as an association. So looking forward to seeing you there in December this year.
My name is Ezekiel Omondi, CEO, Rural Private Hospital Association of Kenya, known as Rupha. Mine is just simple to welcome you to the annual general convention that will take place at Pride Center, Pride Inn Hotel at Westlands on 10th and 11th of December. I therefore welcome all of you to come and bring your ideas, share ideas, meet people, and let's see on ways we can make our health sector be a better place by providing better facilities, technology, and other things that will make our life better. Thank you.
Mwenyekiti wa chama cha Rupha, na wakaribisha wote katika mkutano wetu wa mwaka tarehe 10 na tarehe 11 mwezi wa Disemba mwaka huu. Tutakuwa pale katika ukumbi wa Pride Center katika hoteli ya Pride Inn Westlands. Tunawakaribisha wote ili muweze kuja tuweze kujadiliana kuhusu vile private sector inaweza kuhusika katika mpango wa serikali wa UHC. Karibuni wote.
My name is Dr. David Musita. I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national convention, which shall be held on the 10th and 11th of December 2020. Thank you.
Hi, my name is Dr. Brian Lishenga. I am the chairman of the Rural Private Hospitals Association. The Rural Private Hospitals Association of Kenya is the largest hospital association in the country. We are represented in 43 of the 47 counties, and we currently have over 190 hospitals who are members of the association. And I would like to very warmly welcome you to this year 2020 annual convention of the Rural Private Hospitals Association. We think 2020 has been a mixed bag. We have had a fair of successes, fair share. We have also had some difficult times. And I know that our members out there, hospital providers, can relate to this. Last year, when we had our first annual convention, we were just an association of 92 healthcare facilities. So we've grown by close to 100 members over the last 1 year. Last year, when we had our first annual convention, we were present in 27 counties. Right now, we are present in 43 counties. So we've had phenomenal growth. But at the same time, also, we understand that some of our members have had a very challenging year with the COVID-19 pandemic changing the health landscape. So we've probably seen patient numbers going down. Some of us have been personally affected by the pandemic, maybe losing a workmate, losing a relative. But as the year comes to a close, we are taking this opportunity to come together and take stock of what we've been able to achieve over the last year, and also plan how we move forward. So I am very excited about this year's annual convention. We will be focusing a lot on UHC. We don't want to miss out on that. More than that, as an association, this is the year when we get to launch our strategic plan. And this is something you don't want to miss out on. We want to look at our strategic plan for 2020, 2025, all the great plans that we have for the association. And we think that within the next 5 years, we should not only have the largest hospital association in Kenya, but probably the largest hospital association by membership in Africa. So we are looking forward to seeing you at this year's annual convention, which will be at Pride Center in Westlands, Nairobi, on the 10th and 11th of December. You don't want to miss out on this. We are going to have great discussions on universal healthcare. We are going to have discussions around the NHIF and reforms to the health system. But most importantly, this is the year when we get to launch our strategic plan for 2020 to 2025. So here is where we get to discuss all the great plans, all the things we see the association doing, the future of the association in the next 5 years, how we are able to capitalize on our numbers for economies of scale, how we are able to generate more influence within advocacy, be it in legislation, executive. So this is an exceptionally great time for you to join us. We know it's been a difficult year, but this is, we think, a great way for us to wind the year together as an association. So looking forward to seeing you there in December this year.
My name is Ezekiel Omondi, CEO, Rural Private Hospital Association of Kenya, known as Rupha. Mine is just simple to welcome you to the annual general convention that will take place at Pride Center, Pride Inn Hotel at Westlands on 10th and 11th of December. I therefore welcome all of you to come and bring your ideas, share ideas, meet people, and let's see on ways we can make our health sector be a better place by providing better facilities, technology, and other things that will make our life better. Thank you.
Hamjambo, majina yangu ni Joseph Kariuki, naibu wa mwenyekiti wa chama cha Rupha. Nawakaribisha wote katika mkutano wetu wa mwaka tarehe 10 na tarehe 11 mwezi wa Disemba mwaka huu. Tutakuwa pale katika ukumbi wa Pride Center katika hoteli ya Pride Inn Westlands. Tunawakaribisha wote ili muweze kuja tuweze kujadiliana kuhusu vile private sector inaweza kuhusika katika mpango wa serikali wa UHC. Karibuni wote.
My name is Dr. David Musita. I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national convention, which shall be held on the 10th and 11th of December 2020. Thank you.
Hi, my name is Dr. Brian Lishenga. I am the chairman of the Rural Private Hospitals Association. The Rural Private Hospitals Association of Kenya is the largest hospital association in the country. We are represented in 43 of the 47 counties, and we currently have over 190 hospitals who are members of the association. And I would like to very warmly welcome you to this year 2020 annual convention of the Rural Private Hospitals Association. We think 2020 has been a mixed bag. We have had a fair of successes, fair share. We have also had some difficult times. And I know that our members out there, hospital providers, can relate to this. Last year, when we had our first annual convention, we were just an association of 92 healthcare facilities. So we've grown by close to 100 members over the last 1 year. Last year, when we had our first annual convention, we were present in 27 counties. Right now, we are present in 43 counties. So we've had phenomenal growth. But at the same time, also, we understand that some of our members have had a very challenging year with the COVID-19 pandemic changing the health landscape. So we've probably seen patient numbers going down. Some of us have been personally affected by the pandemic, maybe losing a workmate, losing a relative. But as the year comes to a close, we are taking this opportunity to come together and take stock. Let's take stock of what we've been able to achieve over the last year and also plan how we move forward. So I am very excited about this year's annual convention. We will be focusing a lot on UHC. We don't want to miss out on that. More than that, as an association, this is the year when we get to launch our strategic plan. And this is something you don't want to miss out on. We want to look at our strategic plan for 2020, 2025, all the great plans that we have for the association. And we think that within the next 5 years, we should not only have the largest hospital association in Kenya, but probably the largest hospital association by membership in Africa. So we are looking forward to seeing you at this year's annual convention, which will be at Pride Center in Westlands, Nairobi, on the 10th and 11th of December. You don't want to miss out on this. We are going to have great discussions on universal healthcare. We are going to have discussions around the NHIF and reforms to the health system. But most importantly, this is the year when we get to launch our strategic plan for 2020 to 2025. So here is where we get to discuss all the great plans, all the things we see the association doing, the future of the association in the next 5 years, how we are able to capitalize on our numbers for economies of scale, how we are able to generate more influence within advocacy, be it in legislation, executive. So this is an exceptionally great time for you to join us. We know it's been a difficult year, but this is, we think, a great way for us to wind the year together as an association. So looking forward to seeing you there in December this year.
My name is Ezekiel Omondi, CEO, Rural Private Hospital Association of Kenya, known as Rupha. Mine is just simple to welcome you to the annual general convention that will take place at Pride Center, Pride Inn Hotel at Westlands on 10th and 11th of December. I therefore welcome all of you to come and bring your ideas, share ideas, meet people, and let's see on ways we can make our health sector be a better place by providing better facilities, technology, and other things that will make our life better. Thank you.
Hamjambo, majina yangu ni Joseph Kariuki, naibu wa mwenyekiti wa chama cha Rupha. Nawakaribisha wote katika mkutano wetu wa mwaka tarehe 10 na tarehe 11 mwezi wa Disemba mwaka huu. Tutakuwa pale katika ukumbi wa Pride Center katika hoteli ya Pride Inn Westlands. Tunawakaribisha wote ili muweze kuja tuweze kujadiliana kuhusu vile private sector inaweza kuhusika katika mpango wa serikali wa UHC. Karibuni wote.
My name is Dr. David Musita. I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national convention, which shall be held on the 10th and 11th of December 2020. Thank you.
Hi, my name is Dr. Brian Lishenga. I am the chairman of the Rural Private Hospitals Association. The Rural Private Hospitals Association of Kenya is the largest hospital association in the country. We are represented in 43 of the 47 counties, and we currently have over 190 hospitals who are members of the association. And I would like to very warmly welcome you to this year 2020 annual convention of the Rural Private Hospitals Association. We think 2020 has been a mixed bag. We have had a fair of successes, fair share. We have also had some difficult times. And I know that our members out there, hospital providers, can relate to this. Last year, when we had our first annual convention, we were just an association of 92 healthcare facilities. So we've grown by close to 100 members over the last 1 year. Last year, when we had our first annual convention, we were present in 27 counties. Right now, we are present in 43 counties. So we've had phenomenal growth. But at the same time, also, we understand that some of our members have had a very challenging year with the COVID-19 pandemic changing the health landscape. So we've probably seen patient numbers going down. Some of us have been personally affected by the pandemic, maybe losing a workmate, losing a relative. But as the year comes to a close, we are taking this opportunity to come together and take stock of what we've been able to achieve over the last year, and also plan how we move forward. So I am very excited about this year's annual convention. We will be focusing a lot on UHC. We don't want to miss out on that. More than that, as an association, this is the year when we get to launch our strategic plan. And this is something we don't want to miss out on. We want to look at our strategic plan for 2020, 2025, all the great plans that we have for the association. And we think that within the next 5 years, we should not only have the largest hospital association in Kenya, but probably the largest hospital association by membership in Africa. So we are looking forward to seeing you at this year's annual convention, which will be at Pride Center in Westlands, Nairobi, on the 10th and 11th of December. You don't want to miss out on this. We are going to have great discussions on universal healthcare. We are going to have discussions around NHIF and reforms to the health system. But most importantly, this is the year when we get to launch our strategic plan for 2020 to 2025. So here is where we get to discuss all the great plans, all the things we see the association doing, the future of the association in the next 5 years, how we are able to capitalize on our numbers for economies of scale, how we are able to generate more influence within advocacy, be it in legislation, executive. So this is an exceptionally great time for you to join us. We know it's been a difficult year, but this is, we think, a great way for us to wind the year together as an association. So looking forward to seeing you there in December this year.
My name is Ezekiel Omondi, CEO, Rural Private Hospital Association of Kenya, known as Rupha. Mine is just simple to welcome you to the annual general convention that will take place at Pride Center, Pride Inn Hotel at Westlands on 10th and 11th of December. I therefore welcome all of you to come and bring your ideas, share ideas, meet people, and let's see on ways we can make our health sector be a better place by providing better facilities, technology, and other things that will make our life better. Thank you.
Hamjambo, majina yangu ni Joseph Kariuki, naibu wa mwenyekiti wa chama cha Rupha. Nawakaribisha wote katika mkutano wetu wa mwaka tarehe 10 na tarehe 11 mwezi wa Disemba mwaka huu. Tutakuwa pale katika ukumbi wa Pride Center katika hoteli ya Pride Inn Westlands. Tunawakaribisha wote ili muweze kuja tuweze kujadiliana kuhusu vile private sector inaweza kuhusika katika mpango wa serikali wa UHC. Karibuni wote.
My name is Dr. David Misita. I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national convention, which shall be held on the 10th and 11th of December 2020. Thank you.
Hi, my name is Dr. Brian Lishenga. I am the chairman of the Rural Private Hospitals Association. The Rural Private Hospitals Association of Kenya is the largest hospital association in the country. We are represented in 43 of the 47 counties, and we currently have over 190 hospitals who are members of the association. And I would like to very warmly welcome you to this year 2020 annual convention of the Rural Private Hospitals Association. We think 2020 has been a mixed bag. We have had a fair of successes, fair share. We have also had some difficult times. And I know that our members out there, hospital providers, can relate to this. Last year, when we had our first annual convention, we were just an association of 92 healthcare facilities. So we've grown by close to 100 members over the last 1 year. Last year, when we had our first annual convention, we were present in 27 counties. Right now, we are present in 23 counties. So we've had phenomenal growth. But at the same time, also, we understand that some of our members have had a very challenging year with the COVID-19 pandemic changing the health landscape. So we've probably seen patient numbers going down. Some of us have been personally affected by the pandemic, maybe losing a workmate, losing a relative. But as the year comes to a close, we are taking this opportunity to come together and take stock of what we've been able to achieve over the last year, and also plan how we move forward. So I am very excited about this year's annual convention. We will be focusing a lot on UHC. We don't want to miss out on that. More than that, as an association, this is the year when we get to launch our strategic plan. And this is something we don't want to miss out on. We want to look at our strategic plan for 2020, 2025, all the great plans that we have for the association. And we think that within the next 5 years, we should not only have the largest hospital association in Kenya, but probably the largest hospital association by membership in Africa. So we are looking forward to seeing you at this year's annual convention, which will be at Pride Center in Westlands, Nairobi, on the 10th and 11th of December. You don't want to miss out on this. We are going to have great discussions on universal healthcare, We are going to have discussions around the NHIF and reforms to the health system. But most importantly, this is the year when we get to launch our strategic plan for 2020 to 2025. So here is where we get to discuss all the great plans, all the things we see the association doing, the future of the association in the next 5 years, how we are able to capitalize on our numbers for economies of scale, how we are able to generate more influence within advocacy, be it in legislation, executive. So this is an exceptionally great time for you to join us. We know it's been a difficult year, but this is, we think, a great way for us to wind the year together as an association. So looking forward to seeing you there in December this year.
My name is Ezekiel Omondi, CEO, Rural Private Hospital Association of Kenya, known as Rupha. Mine is just simple to welcome you to the annual general convention that will take place at Pride Center, Pride Inn Hotel at Westlands on 10th and 11th of December. I therefore welcome all of you to come and bring your ideas, share ideas, meet people, and let's see on ways we can make our health sector be a better place by providing better facilities, technology, and other things that will make our life better. Thank you.
Hamjambo, majina yangu ni Joseph Kariuki, naibu wa mwenyekiti wa chama cha Rupha. Nawakaribisha wote katika mkutano wetu wa mwaka tarehe 10 na tarehe 11 mwezi wa Disemba mwaka huu. Tutakuwa pale katika ukumbi wa Pride Center katika hoteli ya Pride Inn Westlands. Tunawakaribisha wote ili muweze kuja tuweze kujadiliana kuhusu vile private sector inaweza kuhusika katika mpango wa serikali wa UHC. Karibuni wote.
My name is Dr. David Musita. I'm the treasurer for the Rural Private Hospitals Association of Kenya. I welcome you to this year's Rupha's annual national convention, which shall be held on the 10th and 11th of December 2020. Thank you.
Hi, my name is Dr. Brian Lishenga. I am the chairman of the Rural Private Hospitals Association. The Rural Private Hospitals Association of Kenya is the largest hospital association in the country. We are represented in 43 of the 47 counties, and we currently have over 190 hospitals who are members of the association. And I would like to very warmly welcome you to this year 2020 annual convention of the Rural Private Hospitals Association. We think 2020 has been a mixed bag. We have had a fair of successes, fair share. We have also had some difficult times. And I know that our members out there, hospital providers, can relate to this. Last year, when we had our first annual convention, we were just an association of 92 healthcare facilities. So we've grown by close to 100 members over the last 1 year. Last year, when we had our first annual convention, we were present in 27 counties. Right now, we are present in 43 counties. So we've had phenomenal growth. But at the same time, also, we understand that some of our members have had a very challenging year with the COVID-19 pandemic.
Good afternoon.
The health landscape.
I wish to call us to order
going down. Some of us
so that we can pick our afternoon sessions.
By the pandemic, maybe losing a workmate, losing a relative.
Can I ask those that are still busy, the exhibition centers to settle down?
Last year, and also plan how we move forward. So I am very excited about this year's annual convention. We will be focusing a lot on UHC. We don't want to miss out on that. More than that, as an association.
Let me have those at the exhibition place to settle down so that we pick our afternoon sessions. I want to believe you had a wonderful time for lunch. And I appreciate that you accepted our offer for lunch. Thank you very much. Without much ado, I would like us to pick on our afternoon sessions. Like I mentioned earlier, we are going to have a slight change where we will have the session from 3:30 down to 5 coming up earlier in your program. So whatever is there between 2 and 3:15 is more of in-house thing. So it will come in the evening as we break to go home. In the meantime, I want us to receive some good presentation from Smart Application. Smart Application are our main sponsors for our convention in the year 2020, and we really appreciate Smart. I said, why don't you put your hands together and we appreciate Smart Application. Like you're aware, we have a wonderful existing MOU with them, whereby we are working on a number of things, and some of the products that we have agreed on are coming up for launch tomorrow. So tomorrow is another exciting day where we are going to see the manifestations of this MOU that we had with Smart Application. I also want to appreciate the team from Smart that has been very busy working with us all through, led by the group CEO, Mr. Harrison Muiru. We really appreciate your hand in making this convention successful. God bless you so much. Without taking much time, I want to bring to this podium the group CEO of Smart Application, Mr. Harrison Muiru, to come and take us through this and henceforth.
Thank you. Thank you very much, and good afternoon, distinguished members of Rupha, the leadership of Rupha, hospital owners, all protocols observed. Good afternoon once again. My name is Harrison Muiru. I am the Group Managing Director of Smart Applications, and I'm happy today on two things. One, previously before the program was changed, I had the uphill task of addressing people who are hungry and looking for lunch, which I don't have now, because I can tell from your faces that we are all energized, having had our lunch and prepared to face the agenda in the afternoon. But two, what is making me particularly happy today is because we are seeing the culmination of a journey that we've walked with Rupha for the last, albeit 2 years. From the videos that you're playing, we could see that our logo is still featuring. We have been walking a journey together, and we believe that in this 2020 AGM, we will turn and open a new leaf with you as our partners as we continue to redefine the healthcare landscape and set a story that will be an example to many other hospitals and hospitals associations across Africa. On behalf of the Smart Board of Directors, our chairman, Dr. Chris Kirubi, and our entire organization, we are glad to partner once again with Rupha on your auspicious 2020 AGM. They say if you want to travel fast, go alone. But if you want to travel far, walk together. And we are glad that we, as Smart Applications, started our journey 16 years ago to introduce the use of technology in the healthcare space across Kenya. This was with a vision to create a society of healthy people through easy, fast, and secure access. And through sustainability, work with our hospital partners to realize this vision. We were the pioneers of digital patient access across hospitals through our biometric smart card technology, which currently is in use by over 1 million Kenyans across 3,000 healthcare facilities facilities in all 47 counties. But this would not have been realized without the healthcare facilities. Through the use of smart systems, through the use of technology, and the acceptance for us to work together, we have seen the realization and mitigation of errors, fraud, wastage, and abuse. And we can see that even our national insurer is following in the example that we have been able to set together as pioneers in that. But SMART has not stopped there. In the next few conversations that we shall have this afternoon, you shall see that we have used that summit that we achieved to launch ourselves to another level of excellence, working with you towards an array of new value proposition, not only stopping at member benefit and claims management, but at full automation of hospital processes, patient access mechanisms, and use of data at your facilities, which we shall show you through our smart hospital management system called Smart Health, our smart analytics, which we shall show you how you can use data to empower efficiencies and effectiveness in your treatment, in your planning across your hospital operation, and other such tools that we shall take you through this afternoon. We have realized that as we talk about realizing the vision of healthcare in this country, be it in whichever way or form, UHC at national level, as was echoed by the former speakers who stood on this panel, or government or county government programs or private programs, the most critical stakeholder, the most essential party and person is the healthcare facility. It is the human healthcare resource personnel. And our journey of empowering you as the stakeholders in this very important element is something that we cannot overemphasize. So today, as we launch our new phase of partnership with Rupha, whom we are very proud of what you have become, whom we are very proud of the muscle that we can see you are commanding today, we realize that we must not tire in our vision of working together in extending healthcare access, optimizing healthcare access, and ensuring that healthcare access is sustainable through the facilities that we run and throughout the society that we serve. We are glad that even during the morning session, a number of issues that were raised are part of the strategic conversations that we are having with the Rupha leadership. For example, accreditation and empanelment, where SMART is working with Rupha to ensure that as many of Rupha members are empaneled within the private medical insurances and as many insurances that we can bring and leverage to Rupha. And one of the guests that we've been invited today is one of these distinguished insurance companies who will be at this podium to talk about that in greater detail. Another element is on automation of your facility management. And we shall see how we take you through our smart health system. And shortly, also the use of data, for which my colleague Sarah will be here shortly to actually show you the kind of insights that you can make out of the data that is running within our facilities. So this can only be the beginning of a new phase of excellence, of changing the face of healthcare in Kenya. Together, we can. So let us continue walking in this journey, and feel free to visit our presentation stand, our demo stand. Onto the left side, we'll be glad to have you and take you through what we have to offer, and also to continue to hear your requirements as your technology partners and in other ways that we can partner to ensure that your individual visions and the vision of Rupha is realized. Asanteni sana, and I look forward to interacting with you.
Wonderful. Bwana CEO, that is a very short and powerful speech. I also want to bring in our sister who will be taking us into the next presentation through by Smart.
Good afternoon, team. I'm glad to be here. My name is Sarah Waithera. I'm from Smart Application, and I'll be taking you through the Smart Business Intelligence Analytics and other data-related solutions that Smart is offering. So just diving right onto it, what you're seeing before you is at a very high level analytics, something that is very evident that COVID did affect the traffic in the private sector, and that is what Smart has covered. But what we have used is sample data for both Rupha members and non-Rupha members. We can all attest to this graph, particularly for outpatient, that in the first quarter of this year, 2020, January, February, March, business was as usual in Kenya. It's not that we didn't have COVID. We did, but probably we were not aware. And then drastically, there was a big drop in April, obviously because we had a lockdown. This brings out the realization that the lockdown was mainly concentrated within the main city, that is Nairobi. And so it means that we have better healthcare facilities in Nairobi, and people in the regional areas of Kenya would rather travel to Nairobi. And so the lockdown contributed to that dip that you're seeing. It was a drop of negative 43%. And the traffic drastically went up in May, but never recovered compared to first quarter. And the traffic continued all the way throughout the lockdown until around October into November, when the lockdown was lifted. We can see a little bit of rise on the traffic. Also throughout this year 2020, using sample data again, I would say that the average costing of outpatient, we would see was ranging in between 4,300, 4,700. And so such analytics can actually give you decision-provoking thoughts. Inpatient was similarly affected across the year, a dip in April, and all through October, a little bit of a rise, and an average costing of around 110, 127, and obviously average costing will always be affected by the number of patients that visit the facility, and especially if the prices have not been reviewed despite the pandemic or despite any inflation that is affecting the country. I'll be open for questions later, but allow me to proceed. With the great coverage that Smart is having across all 47 counties in Kenya, Smart is the best, is in the best place to give analytics that are insightful, decision-provoking, and even predictive. When I say predictive is, when you already have seen how trends are going, then you're able to predict even the next coming quarter or the next coming days. But what we will be offering Rupha for their systems and their members is an outlook across the country of distribution of traffic. How are these locations being trafficked? How are the most prevailing diseases, like the chronic diseases, or even drugs, the most used drugs? so that it can also guide the members on what to restock in their pharmacy. Data is the new gold. Data does provoke decisions, and data can save you a lot of money, especially when providers are planning to open a facility, a big hospital that is planning to open a branch. They're in a better position to approach Smart or to approach any company that has good data to give them advice on the placement of traffic and the services that are being used so that they can be well guided. So you can see the distribution. Obviously, Nairobi is very high. And the obvious reason is because the facilities are quite good, but also the population is quite big as well. And you can see Kiambu is almost similar and next to Nairobi when it comes to traffic and even the cost. Kiambu is densely populated as well, followed by Mombasa, and you can see Kisumu being a little bit low, quite low, very low in fact. If everyone opts to come to Nairobi, then you would expect even the major cities to have low traffic. And so these are the kind of insights that we are going to offer Rupha and their clients. In every angle, if they want to know on procedures also can guide you, and any other category of the services that are being rendered by hospitals. But I want to mention today, and I want to take this opportunity, because we have a hospital representation, a very good representation of the hospital. We are having a major problem when it comes to standardization, something that you've also heard NHIF mention. What is happening even in one particular hospital? I can give an example of, I don't know, and it's just for example purpose. Okay, let me call it provider A. So provider A has 5 satellites, and within their systems, their hospital management system, they have a list of services, but they keep changing the codings, they keep changing the names. And we can obviously see that they've not adapted any type of standard. And it begs the question, is it that we are not aware of the medical standards that are supposed to be adapted? Is it something that we need KMPDB to sensitize and put it as a mandatory for our hospitals? The reason why this is important, it does delay payment for the hospitals. Every time the data is hard to read, every time there's a spelling mistake, every time the data is not standardized in any given period, it's going to delay payment for the providers. So we are urging the providers. Smart does have systems that are already aligned to standards. That is the hospital management system, the SmartLink billing system, already aligned to standards. So you can acquire our systems so that it can also better your payment process. But in the process of you acquiring our systems, we are willing to work with you to improve the standardization required for your own systems. So I really had a burden to mention that in this forum. Thank you. The standards that we have had discussions around with the MOH and the Kenya Healthcare Federation is, as you see on the screen. With the diagnosis, we are heading into ICD-11. Most of us are using ICD-10. ICD-11 is much descriptive. It even gives the underlying reasons for the diagnosis. It might take a while before the local market actually adapts to this. Medication, ATC, but we can also adapt our own local standards. And radiology, there's DICOM and RADLEX, but again, we can always adapt our local standards as we work with MOH. But by all means, we need to work together, and Rupha now will help us in achieving this standardization. For procedures as well, consumable is a whole big list. There's the KEMSA list. And of course, aligning our systems to what we call the unique clinical messaging, the HIPAA. We've all heard of HIPAA standardization. HIPAA ensures that the systems you're running are aligned to handling healthcare data. Not only handling healthcare data and ensuring confidentiality, but also that the output of the data is not giggle, is not garbage in, garbage out. So because SMART is already working on aligning the hospital management system that we have to HIPAA, We don't know what the plans are for the hospitals and the system that they are running, but it would be good that they align to a standard that guides them on how to handle healthcare data information in a way that will also improve the payment process for you. Now, there's a product that we have in Smart. We are currently plugging it in the back end. It is what we call fraud detection and alerts. But we can as well call it an automated adjudication of claims. What we have done with this is from a very high level, we have clinical officers that we have employed in Smart. They've gone through all the categories and they've defined the known administration of all services, the known dosages of drugs, so that, as you've heard, fraud is a big case. Even with smart card, providers and patients have been able to still conduct and carry out fraud. So we have to take this detection to a deeper level where we can identify the service line by line being rendered at the provider level, so that peradventure the drugs they do match the diagnosis being given. That can skip the eyes. But if the dosage and the number of times it's being given to a patient is raising an eyebrow, then our system will definitely flag it as a possible fraud. If the dosage is way beyond what is defined there, if the number of times the patient has gone for that set of drugs, maybe 3 times in a week, we don't know. And I'm sorry, those kind of practices have been caught a number of times, and we want the members of Rupha not to end up on the wrong side of this credibility. So we hope that you'll be open to work with us on this item. So like I said, we have plugged it on the back end, but we want to stop it from the front end while you are billing. And so that one is a projected target for us next year, that we also achieve it on the front-end systems. So as you're billing or as your cashiers are billing, the system has the intelligence to stop them and tell them, this patient was here last week for the same drug, it is not allowed. Or this patient had a cesarean in March, we are in November, it's not possible for them to have another cesarean. And such alerts. Please call the insurance or call the scheme. So we hope that it's a solution that you can appreciate. Allow me to just get a paper from the table. Very fast, allow me to take you through, I don't know what happened. Oh, it's my laptop. With the data that, the sample data that we've used and the coverage that we have, there's an output and behavior that has been picked out throughout the quarters. We all saw how the traffic was, and some items that came up after our lockdown and after COVID was realized in Kenya is that between Q1 and Q2, we had, you can see in Q1, we had acute upper respiratory leading. I'm sorry, it is ascending from below to up. So the highest are at the bottom. And like we said, the first quarter, it was normal business in Kenya. But in the second quarter, after the lockdown and after the COVID realization, we saw some items cropping up in top 25 diagnoses, such as gastritis, which is the erosion of the lining of the stomach, which is an after effect of COVID. Hypertension is a diagnosis in Q2 that moved 3 places up. So it means the condition around and everything was quite stressful. Peptic ulcer moved 5 places up in Q2 after the lockdown. Malaria moved 4 places up in Q2 when we realized the COVID-19. With the malaria, and from the investigation we have, is that most providers in that beginning phase of the COVID era is that they were dispensing the hydroxychloroquine. And also because they realized that most patients are not covered for COVID. So they would treat most patients for malaria. Into Q3, very interesting. Of course, in Q2, most of the items that had already cropped in as the gastritis, the malaria, hypertension, pneumonia, and the acute upper respiratory continued to prevail. But coming into Q3, something very interesting, dental caries took top position. In all of these analytics we've done for the past years, the dental caries has never taken at least top 10 position. And you can see it shoot all the way to the first one. Because of, in the interest of time, I'm not allowed to ask you questions. So from our investigation, the dental caries was because of the mask, the use of a mask. The use of mask and the contamination and the carbon dioxide always being trapped in has seen most patients trafficking the hospital in a high number for dental. Myopia and other related eye diagnoses, as you have seen, there's myopia, there's presbyopia, also shoot to the top diagnosis, meaning that COVID was, and the use of mask must have also affected the eyes. But also in behavioral observation is that probably while the lockdown was announced, most people were not visiting the hospital for those specialized cases and maybe decided to visit. And as I complete this session, into Q4 and Q3, something very interesting cropped on the top 25 diagnoses, and that is the depressive episodes. It is quite real that COVID has really created a lot of stressful situation, and let me not call it depression per se, but depressive episode. And the gastritis issues of the stomach and the lining of the stomach does affect the mental health of any person. So those are the kind of insights that we are asking Rupha to look forward for us to provide for their members, for their system, and any kind of insight and artificial intelligence for predictive analytics that they may need. Thank you.
Let's give a better round of applause. I think I must admit that I didn't know that stuff. Ule mwenye alikuwa anajua anadanganya. I can see some people looking like they are so intelligent, they knew that. You know, like I am personally surprised about the dental caries. Are you guys surprised? Because some of you, maybe that was the time to buy the dental chair. You know, maybe there was a market there. I was also surprised about Q2 and SVD. What happened? SVD just seemed to shoot up in Q2. All the babies were born in Q2. The lockdown. And then the other thing I noticed there was urinary tract infections went up in Q2. I don't know whether you saw that. And those of you who know causes of urinary tract infection, Dr. Cesar Makara can tell us that people were very busy in Q2, if you understand what I mean, with the lockdown. All right, but I think this is a wonderful presentation, great analytics. Just to move the process forward, we are slightly behind time. Where is the next smart presentation? I know we still have various groups, CDMS, to present. I'm aware you are on the program, the chance will be there. But we are still running very well to get through this. Karibu.
Okay, thank you very much, and Good afternoon once again. You have seen the power of data. So we are in technology, but from the presentation that Sarah has done, she was explaining medical terms to the doctor, and the doctor's here. So I'll take you through a presentation. Thank you. Okay, thank you. Thank you for that. So my name is John Goloma. I'll from Smart Applications. I'll take you through a presentation on biometric registration of the members and also time and attendance. So from what the presentations that were done in the morning, there is the importance of member management and proper member management using biometrics. So in terms of member enrollment, the solution that we do have is for member registration, both on site and off site, that is at the hospital. And also when you're doing a campaign, maybe you're trying to register the members out there, the system is able to do that. And of course, there's also the advantage of both online and offline capabilities and mobile, as you will see shortly. So in terms of the biometric or the biodata, you are able to capture all the information on the member, that is the biodata, from the name of the member and also the socio-economic factors and information as desired. So the advantage of the solutions that we provide is that they are customizable, and therefore there's that flexibility whereby whatever information and data that you want to capture, we can be able to customize the solution and application to be able to work as per your requirements. And of course, there's also the fingerprint registration, which I'll show you shortly. Then there's also the facial capture of the member that we're registering. And the system is able to register both the principal member and the dependents. And for the principal member, as you will see shortly, we are able to tag the information. So if I'm the principal member, all my dependents will be under me. And therefore, there's a unique identifier that is going to be generated by the system. And this is what we will be using to identify the member. But the unique identifier is going to be the fingerprint. And therefore, you present your fingerprint and you're able to get and access services at the healthcare facility. So now the other solution that I want to speak about is the time and attendance and access control system using biometrics, which is a simple and fast time and attendance system. And it is an easy to use solution that has options for both fingerprint and also face recognition. I know during the COVID situation, most people have been very skeptical with the use of fingerprint, but we also have contactless biometrics, whereby you don't have to touch any devices or any equipment. You just present your face, you get registered, and then subsequently, you are able to either clock in or access a specific office location, because the system covers both time and attendance, that is clock in and clock out, and access control. Access control to be able to restrict specific office locations, because I know that there are areas that are not supposed to be accessible by just anyone. And a good example will be like the cash office. We also have the server rooms that are only supposed to be accessible by specific people. And it's a system that can cater for single or multiple office locations there, which is interconnected. And therefore, we can be able to centralize all this information. An example, if it's a hospital that has branches across the country, and let's say you are seated in Nairobi as the head office, or in Kisumu, your head office, and you have a branch in Mandera, you are able to see what is happening in Mandera because we are able to ride on the infrastructure that you already have in place. And therefore, you don't have to move and incur that cost of having to send somebody to give you the data from time to time. At the comfort of your desk, you're able to log in and access all that information and that data. And then the beauty about the system is that it's able to integrate to the existing system at the workplace. If you have a HR system or an ERP system, the system is able to cater for that because you want to be able to have an application and a system that is able to communicate with the existing application. And therefore, if you are doing processing of payroll, it becomes easy because the system is able to compute the timestamps for you. So the only thing that happens now is that that information is relayed or transmitted to your payroll system, and it's able to do the processing for you based on the number of hours that maybe the personnel or the staff have worked for a given period of time. Then there's reports on analytics on what is happening, and in terms of attendance, you're able to see the early clock-ins or the early arrivals, able to provide. Then now in terms of the benefits, it's a very easy and convenient system to use. You don't need to have a lot of training in order for you to be able to access the system. And I know that most people, or most of us, whenever we hear about biometrics, we know that that kind of science is very complicated, but we ensure that we walk the journey with you. And therefore, in terms of hand-holding, in terms of transferring the knowledge, we ensure that we are able to have competent users in terms of the system, and also availability. We are available to offer the support and also to be able to, in terms of reachability, the call center, which is 24/7. So in case of any support, you are able to reach us. As I had mentioned about the accurate data, because the data is automated. And therefore, this time, we are not using a book somewhere, or we don't have anybody manipulating. It's a role-based system, and therefore access is only allowed specifically for those who have access to the system. Therefore, that means that the timestamps will be automated, and therefore that data and that information is accurate. And of course, there's elimination of body punching, where I can send my colleague or my friend and write on my behalf. In this case now, remember we are using our features. In this case, either your face or your fingerprint. And therefore that means that you have to be present. And I know that there are other options that sometimes you find organizations prefer. The use of a card, which we normally refer to as a radio frequency identification card or RFID. Therefore, with that, we employ something we call multi-factor authentication, whereby you tap your card and then you have to present either your face or your fingerprint. That means that you have to be present to either clock in or clock out or that specific office location. And if any dispute, log into the system, able to get that information, that data. Then centralization in terms of reporting, as I had mentioned, which reduces administrative costs and easy integration capabilities. And it's a system that is ideal for any office size. Whether it is a single office or whether it is multiple offices that are interconnected and distributed across the counties or across a given area. So that is it about the system. And these are just some of the customers where we have implemented the system, the likes of Aga Khan University Hospital, Nairobi, and all its outreach clinics, Kenya Alliance, Green Blood Growers, Body Nursing Star. So allow me to take you through just a small demo for the biometric member enrollment. Okay, thank you very much. So I'll take you through the biometric enrollment solution for member enrollment and verification. So it's an application and a solution that we have developed in-house. And as I had mentioned, the flexibility in terms of customizations. So there's registration both for the dependent and also for the principal member. So just let me go through the principal member quickly, whereby we can have a new registration, an existing member where you want to change some details, and all other parameters. Is the member over 65 with dependents or 5 years with. Therefore, I'll just capture the data quickly. So we have the surname, then we have the other names, then enough principal members where they have to be at least 18 years and above. Okay, so just a generic date, then the telephone number, the occupation, the two, the level of education, we capture that. Then we go next. Then now in terms of location of this particular member, can be able to capture all that information. So the county where we have the member, then the ward, the sub wards, then the village as well. After that, now we go to do a small survey. Now the survey is based on information that you want to capture, which you can use maybe to be able to enhance the cover that you have. So in this case, these are some of the parameters that we have. Does the member have any disability? If there is, then you specify. Then is there any chronic ailment? Then you are able to specify as well. So an example, let me just say like diabetes. Then have you been admitted to hospital in the past 1 year? If yes, then you mention that the number of times you specify, let's say like twice. Okay. Then the information continues. Have you spent money out of pocket for medical treatment in the past 1 year? If yes, then you specify the amount that has been spent. Then have you sold property to settle a hospital bill? If there is that, you specify. Then is there any other form of medical insurance? So if there is, then you are able to proceed and specify on the system. Then once we capture that, we proceed now to biometric registration, where we capture the fingerprint for the member. So you can capture as many as all the 10 fingerprints, but for now, allow me just to capture at least one. Okay. Then I have my fingerprint reader. It's connected to the phone, as you can see here, through an OTG device. So as I had mentioned, you can register members both on phone and also on the PC. Okay. We're trying to capture the image and our fingerprint. Okay, there we have it. Then we go next. Now we want to capture the photo of the member. Okay. Then once that is done, we complete our registration process, and that information has been captured. So as I had mentioned, the system is capable of managing both online and offline registrations. So you are able to register the members and you're able to see. So sorry for that. But my registration has been successful, and I've been given a new registration number, which I can use subsequently anytime I go to hospital. But as long as I have my fingerprint, which is the unique identifier, then I'm able just to place it. And also the turnaround times in terms of accessing services is even faster And you are able even to positively identify the members who are accessing services, including the dependents as well. So that, in a nutshell, is the solution that we wanted to share with you today. Thank you very much.
All right, thank you. Thank you very much. Remind me your name.
John.
Okay, so another round of applause for my friend John. I hope that you have captured some interesting points in that. I was very fascinated by the last one, where he was doing the member registration. And I was actually wondering how you are capturing the detail before you lifted the fingerprint device. But I don't know about my friends out there, but personally very impressed by the fact that you can do it with a phone, you know, a smartphone from your pocket, and that thing which you can even carry also in your pocket and be able to do that. But it's a wonderful presentation. Now, I think that some of us might be asking why this kind of presentation from smart applications, and I feel like I should point out this, which I think it must have struck some of you by now. I was having my lunch with Dennis Barake, our friend from Nyamira. Where are you? Where's my Nyamira friend? I cannot see you. Ameenda wapi? Na mwingine alikuwa nani? Was it Job? Yes, there, right there. Our friends there traveled a very long distance. And these colleagues are struggling with this issue of declaration by NHIF. In fact, I would not be lying to say that was one of the major motivations for joining Rupha. And they also reminded me that hiyo isipokuwa sorted, watu wataanza kuhama. Is it true? Is it true? Nani anataka kuhama na lunch kama hii bwana? But really, the point is this, guys. There was a question that they were raising during lunch. When I placed it to Kohora, whether they will stop declaring facilities or they have stopped. I think you remember the answer. Very direct answer. He said, we have and we shall, isn't it? He said, we have and we shall. Now, obviously, as an association, we must keep fighting for our members to get accredited. But one of the solutions we are really seriously thinking about as an EXCOM is to find a way that this network that we are building can actually tap into the large market out there. And personally, as an association ourselves, be able to actually carry a card that is valid at Rupha facilities. You understand how we are thinking? We need to be able to think like that, because I think that in the future, it is probable that some of us, our investment will go to West unless we start to think of alternatives. And so this is a wonderful, thing that Smart is putting on the table. This is the direction we need to think about. We need to think about in-house solutions to the challenges in the health system. And look, I always argue this way. NHIF does not have a single hospital. They don't have one hospital in Kenya. Who are they relying on? Who are they relying on? They are relying on us, isn't it? Okay, so imagine if we decided to be our own NHIF. Who will they rely on? No one, isn't it? Thank you. So I hope you get the line of thinking. Next presentation. Now this one we have to keep it short. Naona ni kama time imeenda. So, welcome.
Good afternoon. My name is Timothy Mwamba. My name is Timothy Mwamba. I'm from Kenyan Alliance Insurance Company. I'm the head of healthcare. There we don't call it medical insurance, we call it healthcare insurance. And I'm glad to be part of this team and of course to be part of the partnerships that we are having with you. Of course, some of you, we have already accredited you. You are part of our service providers. Our clients are able to use our cards in your facilities and obtain medical services. I'll just mention quickly who Kenyan Alliance is, and then I will take us through a very brief discussion on the accreditation process. Kenyan Alliance is an insurance company that is composite. We've been around for since 1915. We have been, we are able to trade in various lines of insurance, both short-term and long-term insurances. We do have a wealth of insurance in various classes of business. For example, in the, of course, I've already mentioned life, medical, and pension. We have a wealth of insurance in terms of like farming, in the manufacturing sector, in tourism, and also in construction, among many others. We provide health solutions as well. We provide health solutions as part of our packages. Just to mention also that apart from medical, we are able to provide solutions like personal accident. We are able to provide cover for motor vehicles, professional indemnity for you as professionals. We're able to provide cover for your buildings so that when you are carrying out business, you have peace of mind that your buildings, your appliances are safe. Of course, we also provide solutions for pensions. I know some of you have staff who would want to take care of the pension plans. We have those kinds of solutions as well. Education plans. We also have group personal accident, and there are quite a number of solutions. And specifically for medical, we provide solutions for group medical covers for any group of registered clients who are 10 and above. We also have SME solutions for those who are like 3 to 4 and even 5, and also family cover. We believe that our healthcare is able to provide distinction value in the market. And I know some of you have already seen our clients carrying medical cards. And so the various propositions of value that we are giving, and the reason why I'm mentioning this is because we'll want to partner with you in some of those areas. For example, delivering drugs to our clients. Sometimes there are clients who just have, probably they are at home and they want to get regular medication. For example, the regular refills that people have. And so we are able to do that. So we shall be reaching out to you so that we can have that kind of partnerships. Of course, we are looking at other areas like even telemedicine and such, which I know we are able to provide those kinds of solutions. Now, coming to accreditation, I want to say that private health insurance, we are open. We don't have a tedious process of accrediting hospitals or clinics or even individual specialists. We have a certain checklist that we have that we, of course, require that you should be able to provide. One of which is a certificate of registration. Tax compliance is very important. PIN certificate, and of course, a license from the Kenya Medical Practitioners and Dentist Board. We always want to have the profile of your clinic or your facility so that at least you're able to know what kind of services are you having. When we want to refer our clients, we will want to know if I send my client to this facility, they'll be able to access that service that they need. So that we don't, for example, dispatch an ambulance to your facility, and they only get there and they're disappointed. So the profile is very crucial to us. And then the CV of the in-charge doctor, or at least the key personnel, so that we also get to know that we are dealing with people who are professional. Of course, you heard the other time, not long ago, we have facilities out there that are being run by people who are not qualified. And so we will want to guard against such, so that our clients are assured of quality, they are assured of reliable service. Professional indemnity cover is also very crucial. And I know some of us do not have that, and we are open. You can get it from us or from any other insurance company, but of course we'll want you to take Kenyan Alliance cover as your preferred insurance provider. We'll definitely want to have the price list. The price list helps us to gauge and be able to see what are you charging for which specific service. Of course, we have challenges sometimes when service has been offered or it's being offered because probably there was no pre-agreed price. Then doctors or the administrators within the facilities are now begin to adjust the prices. But once we have this price list, we are able to put it within our system. And so we anticipate that when a service is being offered, it will attract a certain amount of money. And then, of course, the contact details. Sometimes we want to do a referral, or you want to get a clarification, or you want to give a communication. We'll want to have a list of contact persons and their details, so that we have it in the database and we are able to make the communication to be very clear. Like recently, we were communicating about our jump into the e-claim platform, where we want you to be able to submit the claims on the platform, the portal that we have within the smart provision. And so when we want to make that kind of communication, it's important that you have that. And finally, very important is the bank details. How do we make payments to you? And it's important that also you provide that. I just want to say that we as an insurance company, we are really looking out for opportunities of partnerships with you. Sometimes we have packages that we want to provide to clients at the mashinani level. Maybe I have a client who is based in Busia and will want to give certain packages, for example, wellness packages. We are open for such kind of discussions so that we can help one another to add value to the client of whom we are mutual beneficiaries. That is my presentation, and it is as short as that. Thank you very much.
Thank you very much, Timothy. We will have a very last presenter who will be taking us through the Smart Management Information System. My name is Esther. I head hospital operations at Smart. Many of you have interacted with me. I was in the conference last year. I take care of all of you at Smart, so I am very happy to be here. This is actually my event with Brian, and we shall walk the journey with you guys. So Justin, please be walking here quickly so that we can wrap up the presentation this afternoon.
Good afternoon, everyone. My name is Justin Mugi. I work with Smart Applications. I'll be taking you through the hospital management information system, which is, we call the Smart Health Plus. So this is a solution that you've developed internally. And because of our experience in the market, we have been able to collect the views from hospitals across the country. And we definitely know that whatever we have in place is what that the hospitals require so that they can resolve some of the challenges that they are facing in their operations. Again, there was a discussion about data. So this is the first point where you start the journey of using your data to work for you. So I'll start with the introducing the system. It's a web-based system, which means that this system, even when you are not at the facility, you can be able to access it through connecting to the internet. So when you have this system with you, the operations of the hospital become much easier because you, even when you, for example, you've come for a function like this, you'll be able to access the system and probably get to know what is currently happening at the hospital. So the first module of this system is a dashboard. So the dashboard just gives you a brief preview of exactly what is going on. You can have the active visits, patients that are waiting appointments, those that are on queue, and the total number of visits that you've had. So the system also has a patient management module. The patient management module has helps you to register your patients when they visit the hospital. It also helps you to get the information about your patient, those that have already been registered or that have previous visits. And if it's totally a new patient who has never been at the hospital, you'll be able to record their details. So at this point where you're recording the details of a new patient, you are able to get the bio details of the patient. And again, nowadays, the phone number is actually very important. Why is that the reason? You'll find that we are able to connect this system with an SMS platform, which means that if you, for example, want to have a rapport with your patients, you'll be able to automatically communicate to them. If it is things to do with appointments, we can be able to set auto reminders for appointments through the SMS platform. And actually that helps you and ensures that patients don't miss their appointments. Again, we are able to monitor the journey of the patient. So when the patient is queued into the system, you can be able to actually monitor and tell how long they have taken in the various departments. So you can see, for example, this particular patient was queued for consultation at this particular time. So this journey definitely allows you to know the turnaround time of the patient and helps you to improve your service delivery. And the triage, when the patient has been queued, most times you find that the patient goes to the triage before they go and see the doctor. So at this point, the triage nurse is able to record the vitals of the patient. You're able to take the triage notes, and also if there are any allergies, you're able to record them. Then the patient will proceed to the doctor, to the consultation room, where the doctor now will have a queue of the patient. And from this queue, the doctor, the system is able to prioritize. If, for example, it's a patient who has come with maybe it's an emergency case, the system, it can be defined at the triage, then the doctor will be able to see the queue as per the urgency of that particular patient. If when the doctor gets to see the information about the patient, you're able to see the vitals, that he also present to you the historical vitals of that patient. Anything that has ever been recorded regarding the patient will be displayed. If there are any notes about that patient, they'll also be recorded. They will also be displayed. If there are any allergies, if the doctor also wants to add some vitals or maybe some notes for the triage, they can also be able to do that. Then the doctor will be able to do the history and treatment, so that you're able to now have a conversation with the patient and get to understand what the patient is suffering from. And again, the system provides for you the history of the visit. If the patient was there previously, it is able to give you the history so that it becomes much easier for you to interact with the patient and also to identify what the patient is suffering from. We have provided the ICD-10 diagnosis as per what Sarah presented to us. You're able to send prescriptions to the pharmacy. You're also able to see the lab results. After the results come from the lab, you're able to see that. You can do a seek-off from the system, and also you can be able to do a referral. The doctor has requested for a procedure, lab, or pharmacy. That will be displayed from the various modules. If it is a procedure, you are at the procedure room, they'll be able to see this. Then at the lab, again, they'll be able to see the details of the lab, and they'll go ahead and do the test. And those tests will again go back to the consultation room. Then the pharmacy, the requests that have been made by the doctor, the prescription will be available, and the drugs that are supposed to be dispensed will be available, and the pharmacists will be able now to go ahead and do the dispense the drugs. Under radiology, we are able to load for you the templates for radiology, so that as you do the study, you're able to have it done for that particular patient. And again, that information goes back to the consultation room. We have a module for data. So you can be able to manage your data if you have data, and also inpatient for those facilities that have inpatient. So you'll be able to manage your admissions. If, for example, you want to see details of this particular patient, it can be able to display for you the admission details. You can also be able to see the care team for that particular patient, details of the patient bills, the progress. I know at some point the patient may want to get the interim bill. You can be able to print that for the patient. And then when you're discharging the patient, you'll be able to do the discharge summary, and it will be presented on the system. Then ward management, you can be able to manage your ward. If you have several wards, then you'll be able to manage them through the setup of the ward. Again, you can indicate the beds within the ward can also be managed. We're able to also have the NHIF rebate. I know that there is a requirement when for NHIF when you're billing an NHIF patient, so that will also be availed to you on this system, and you'll be able to fully manage the NHIF transactions. Something else maybe to mention at this juncture, you're able to also set limits. I know for NHIF, for various facilities, there's provision for limits. So if you have particular limits that have been set for you, or you've agreed with NHIF, you'll be able to now track that and ensure that you don't go beyond the limit. We're also able to do capitation. We can be able to set the amount for capitation for your various customers. And again, we are able to do multi-pricing. I know the previous speaker has mentioned about the price book. So you can upload as many price books as possible on this particular system. If you have a discussion with an insurance company, or maybe one of your clients, and you've agreed on particular prices, you'll be able to update that, and the system will automatically effect that as you're billing the patients. So you'll be able to do the discharge and the inpatient, and that's the information to do with the inpatient management. And the billing, you'll be able to track the payments for the patient. So we can do it in 2 ways. There are times where you want the patient to pay first, probably before they access the service, or they pay later. It all depends on the setup of the hospital, and that can be able to, we can be able to configure that for you. Then you're able to track the receipts and also the invoices. You can see the history of the invoices. And then under change payment method, there are instances where a patient has probably been queued as an insurance client, but maybe there are some services that are not billed for insurance, and they choose to pay cash. So you can change the method of payment, and that way you will be able to bill that patient. Then under accounting, we have a full accounting module, which means that you don't need another system to supplement this. You'll be able to set up your charts of accounts, and also all the process of ledgers. You'll also be able to get the journals, and you can track various transactions. You can be able to reverse transactions using the journal entries. You'll be able to track your banks. You can we set up the banks, and you can see the various transactions on your banks. Then if you have consultant doctors who have you have an agreement with them, whereby they charge a particular amount for a particular service, that can be set up. It can either be in form of a percentage or even an amount. And that way, you're able to tell how much you owe a particular consultant. Probably you pay them on a monthly level or maybe daily after every service. That becomes very easy for you to do the reconciliation. You'll be able to see the expenses that you're generating from probably suppliers, also the consultancy bills. And after you're able to view that, you can be able to make the payment. So all the suppliers can be managed under the stock and inventory module, whereby you have to record all the suppliers as we are going to see. And then that way, you'll be able to track your expenses. Then when you receive payment from those credit paying patients, or companies, you're able to record that particular payment. The reason why this is important is because under claims management, you have a module for claims management, you are able to allocate those particular invoices. So the system helps you to do auto allocation of the invoices after the payment has been done. And that again makes it very easy for you to do the reconciliation of claims. Shift management, you may find that you have several cashiers that are collecting cash. So you can be able to set up their shifts, and every shift, you can be able to tell how much has been collected. You'll be able to manage your petty cash. And again, we're going to see a full module for reporting down. But maybe let's highlight a few things on the stock and inventory. You're able to record all your suppliers. You're able to do a purchase order. Then after purchase order, you can do purchase receive. After you do purchase receive, you can be able to do stock transfers. Maybe you're doing transfers across departments, or maybe you have several branches. And again, something I would like to mention at this point, the system has a capability which we call multi-tenancy. Multi-tenancy means that you can be able to manage several facilities under this one umbrella. So which means that for those functionalities that are shared, probably accounting, you want to know how the performance of the various clinics is happening, you can be able to do that centrally on the system. If you want to probably manage things like drugs, you want to have a centralized patient register, that is also available on this particular system. Then under claims management, you'll be able to see all the invoices that have been generated as the patients walk in or as you do the billing. You can be able to amend invoices, but again, you only amend invoices when they are on their interim phase. But when you've closed the invoice, it's not possible to do the amendment to avoid instances of fraud. So you can also be able to merge invoices if you've generated several invoices. Maybe sometimes you find a patient has come, the invoice has already been generated, but maybe there is a particular service that probably was never billed for some reason. Then you'll be able to merge those invoices. Though this is what I mentioned about allocation of receipts. When you've received money from the payer, it could be an insurance company, it could be a company you have credit terms with, you'll be able to do the allocation. It can either be, you can be able to allocate one by one, or maybe you do a bulk upload, and then the system does auto allocation. So before you do all that, then it means that you need to first do a dispatch. So you'll be able to see all the invoices that have been billed, and you can be able to filter the period of the invoice that you need to dispatch. And after you're able to confirm that those are the invoices you have, then you can dispatch. Currently, the dispatch is only done at the system level, but you're going to get to a point where we fully integrate with our system so that the whole process is one, where the invoices are able to go straight to the insurance company after you do the dispatch, and the payment is also done, and all that information becomes one. And again, to mention, This system is already integrated with our MediSmart system, the one that is already running at your health facilities. So reconciliation of claims becomes very easy because you have an integrated platform. So issues to do with the errors in when maybe someone is billing or maybe some of the claims have been left out are very minimal because of the integration aspect. And again, if there are other systems that you would want us to integrate with, is also very much possible because we are doing the development in-house. So basically that's how our system, that's the outlook of a system. It's a very big system. We have a full module for reports. You can be able to generate the balance sheet. You can do the P&L. You can be able to get the trial balance. You can get the daily reports whereby you want to know the transactions that happened for that particular day. You can filter them per service, per department. All that information is available. And maybe last but not least, this system, as you can see, it has quite a number of modules. It's a role-based system, which means that not everyone will access everything. If, for example, your role is to record patients, we are able to assign that particular right for that particular individual, and they'll only be able to view the patient management module. If it's probably someone whose work is only consultation, maybe it's a doctor, they will not be able to see all these. Even on the reports, if you're not allowed to see the reports, then you'll only be, we are able to assign those rights for those particular individuals. So we have a team on our desk there. So if you need further information regarding this particular system, we'll be able to discuss further. We can also arrange for presentations, both remotely or even physically, and kindly feel very free to engage us so that we can walk this journey together. So the system is already running in some of your members, and I know Favor Medical Center, the system is there. We also have it at New Point Hospital, and I hope, and I'm very sure the system is serving them well. So thank you very much.
All right, thank you so much, Justine. I just wanted to mention that we have a special pricing for Rupha members. So you could visit our desk. We will be sharing the pricing matrix for the system, and we'll be able to explain further on how the system works. Thank you so much. Unless Brian will take questions for us.
Not taking any questions. Another round of applause for Smart. I think you heard him mention that the system is running at Favor Medical and New Point Hospital. Now, for the sake of open disclosure and honesty, Favor Medical is the vice chairman's hospital. New Point Hospital is the chairman's hospital. Lakini hatukulipwa. I think, in fact, I was rather surprised to learn that you are running on the system, that Kariuki was already running the system at Favor. And we came in later. As we are talking now, Esther's team of developers is actually in Joro, in Nakuru, installing this patient management system for New Point Hospital. And I know we are going to have a nice experience, yes, and we look forward. Otherwise, tutaambia members, tafadhali usiguse ama namna gani? No, I'm joking. Yeah, but I mean, so far your support has been tremendous. Now, my friend was going to do us a bio break. You ready? You ready? So Evans from, tell me, I know it's the other one, Ravine, isn't it? Come.
Good afternoon, everybody. Those that are at the back, can you hear me? Bwana Yesu asifiwe. Praise the name of the living God. All right, thank you. To all the protocol observe and my fellow colleagues that have joined us today, this is a very good engagement, and I hope everybody is enjoying being here. there is no time that we are wasting. It's a very productive engagement, and I hope after this session, there are many things that we'll have learned. Sinikweli. So let's get something, okay? And wealth is health, and health is wealth. Is it true? Not true. So you have to be very careful before you say yes or no. We must get our health right so that we can make wealth. And if you don't take good care of your health, you will use all your wealth to make your health right. I want us to do a small exercise, and we are all informed that all the protocols of the COVID-19 and the MOH guidelines are observed. So I hope everybody's at 1.5 meters away. So if I say that we stretch 1.5 meters away, will give you an opportunity of not touching anybody. So let's start from that point. Let's all arise. And because I know everybody likes this session, it's going to be a very small procedure that is not going to take us not more than 3 or 4 minutes, and we shall have been done and get back to the normal running of the activity. So I hope we are okay. Are we comfortable this way? And everybody should be able to control their body, because I believe we do exercise every day. Okay? So let's move. If you touch the person next to you, then you are not observing the COVID-19 rules. I want us to go down. For those that are doing exercise, this is now the time to show your ability. Let's move. Let's stay there for around 4 minutes. I can see those that are not doing exercise already started standing up. Let's go down, not up. Up, down. If you are happy and you know, clap your hands. Somebody is down and we are clapping our hands when we are high. Otherwise, thank you. Have a blessed day.
Thank you very much. That is Ravine Glory, all the way from Baringo County. Thank you so much. At least Jogoo wa shamba ameweka mjini for the first time. We are going to hear again a short presentation. And this time I want to call an organization called CDMS. They are also our sponsors. And we also have a deal with them tomorrow. We'll be signing an MOU with them tomorrow on how we'll be operating. CDMS is led by none other but our brother Sam Agutu. Put your hands together for brother Sam.
Where was the presentation? Oh, I thought it was actually put there. Excuse me.
It's here.
I thought it was loaded here.
Yeah, it is.
You got it? Oh, that's perfect.
Yeah.
See here, see here.
No, not that one.
See here.
Look, here, just bring my bag. Bring my laptop. My laptop bag.
It has the flash, right? So
Yeah.
just press the flash.
I thought that they had loaded it here.
No, yeah, no. The one at the back is what is.
So meanwhile, as they get ready, let me take the opportunity to show you some of this merchandise if you've seen it. Notebook. We took your comments from last time. Last year zilikuwa na tarehe. They had January, February, March, April, and then they were written 2019. The comments we got were, I want to use it after 2019, I can't use it. I think that was the feedback. So if you look at them this year, this one's hazina tare, they're just plain notebooks. So you probably can use this for a long time. Although it was my strong suspicion There are those people who are saying that were avoiding to buy in future conventions. But it is over here, and you can buy this item to support the association, support yourselves. I think this is going for how much? How much is the notebook, Zekai? 800. Kuna wale wamesha. So you can grab yourself. There's this polo t-shirts. This is XXL, and I believe this is the right size for myself, Evans Majune, and Samuel. This is the perfect size for us. These polo t-shirts are going for 1,000, I believe. And then we have the round neck. How much are these ones going for? How much are these ones going for? 750. Grab one for somebody back at home when you'll be going there. I think the other item is which one? Water bottle, where is it? Yeah, water bottle. I think you've seen this water bottle. Our solid looks very nice. Last year we had the, what are they called? Thermos, the flasks. And the feedback was, hizo ziliharibika hata before mfike home. That was the feedback. You try putting something. And, so this time we didn't want to risk. And the suggestion was just carry water. So these ones are going for 1,200. They are right there at the back. You can buy to support the association. What? Cups. Mug. Who still has, this from last year? This year. So mugs. E-mug. This mug is so expensive. If you bought this mug, usitumie kunywa chai. Just keep it as a souvenir. How much is this mug? This mug is 750. No. This is not for tea. This is souvenir. If you're going to use this for tea, make sure it is very expensive tea for this one. All right, so just wanted to let you know about these items. Now, these items, we purchase them from the money that the members contribute. We make them. And so we put a small markup on them because, I mean, the association has to be self-sustaining, not only for the current EXCOM, but for future EXCOMs. Because if we ever go to a point where we don't have resources, it's going to be very difficult to get things done. I think you've seen some of our media engagements. You've seen some of them, isn't it? Sometimes we call press conferences and we give statements about things. I mean, I would like you to know those things are not for free. For instance, if we call a press conference to talk about private COVID, we get KTN, NTV, whoever, they come there, they charge. They say, and they charge depending on what slot you want. Sasa, it's like a market. Munataka kuonekana saa 3, saa 1, saa 10, ama saa 7. So obviously, if you pay less, utaonekana saa ngapi? 11 p.m. You know that slot at 11 p.m. So, I mean, and this is all about keeping visibility. Part of the reason why we have grown in influence as an association is because of our media presence. Just being out there in the news, getting talked about, this kind of forums. In fact, one of my friends from CAF, Kenya Association of Private Hospitals, who are our friends now, they were not before, but they were saying, the comment on their platform was, we have to give it to Rupha. The one thing Rupha has managed to do is to stay relevant in the news, in the city. Everybody, every time you hear about Rupha. But I think for the vision that we should have for the association, we have not even reached the level of relevance that we require for us to be able to make things happen. At some point, it was difficult for, where's Kefa? Kefa was making me laugh. Kefa from Maimahiu. He was telling me he even got a call from his branch manager. Kamwambia umenishtaki. And Kefa was like, no, we have a very good relationship. But apparently, one of the members from that area called the EXCOM. The EXCOM talked to somebody at NHIF, said, things are not very good. The branch manager got a call and he panicked. And he was like, Rupha is coming for your neck. You understand? When I was here just now, I hope you are ready. When I was here just now with Douglas was saying, when we had your presentation, he had my presentation with the Senate Health Committee. He thought I am this aggressive bully person. Alafu anakuja hapa alafu naona wewe ni hivi unakaa kijana tu. So I mean the point is we are literally investing for influence. You understand what I'm saying? We are investing for influence. And so don't stop believing in it. Keep doing what you're doing. Thanks.
Thank you very much, Brian. Good afternoon, ladies and gentlemen. My name is Sam Agutu. I'm the CEO of CDMS, the Chronic Drugs Medical Scheme, and I've got a brief presentation for you. It's always difficult presenting at the end of the day when people's interest is, or blood sugar levels have gone down, but I hope that you'll give me your 10 minutes. Now, CDMS, Chronic Drugs Medical Scheme, we are a social enterprise. A social enterprise is an enterprise that first and foremost believes in social impact in everything that it does. So we are an enterprise in that we do business and sustain ourselves, but overall, the key thing is that we must create social impact. The founders of and pioneers of CDMS, including myself, have been in this market for several years in the insurance industry, developing mobile-based health financing, microinsurance products, using smart cards. So, we had a product by 2011 called Linda Jamii, which was a pioneering product. Our mission is to facilitate the delivery of affordable but high quality patient experience. So patient experience is at the key at the core of what we do. And to do this, targeting low income populations through strategic partnerships like the one that we are going to have with yourselves. And these are interventions in the health delivery value chain to ensure that the overall patient experience is enhanced. So in this particular presentation, we'll be looking at two interventions that we have that seek to achieve this objective. We are getting into a partnership with Rupha, and this vehicle here is to just explain to you what this partnership is going to deliver. The first thing is that our Tibanite online pharmaceutical group procurement solution for hospitals. This is, an aggregation of demand among small hospitals to then be able to procure good prices and discounts for small hospitals. It delivers not just lower costs, but convenience, transparency, and a wide range of suppliers. As you can see, our solution will be accessed online by you on either your laptop or even on your smartphones. The process is easy, logging in, processing or membership, there's no charge. All you need to do is to log in, to register. There's a registration form, and you need to, give in a few details, and it enables you then to, shop, look around, look at their various manufacturers, various suppliers, various distributors, and be able to select products, that you can, buy, and use M-Pesa, Paybill to, make your payments. There are discussions that we've had with your executive committee about, how to handle purchases on credit. Now, as the engagement goes on, we will be able to, give further clarity on the sort of credit terms that will be offered to hospitals. And then you do click on the cart, which is shown right there, and that enables you to check out, and your goods are then delivered.
The other intervention that we have is training. There is a clear understanding that the quality of patient engagement can be compromised if health workers do not update themselves or are not regularly updated on the latest trends. And so we have put in place a set of training packages targeting both clinical training and non-clinical training. For example, we do have training on stock management or just finance or bookkeeping, right? Apart from specialized cases of clinical training, for example, on management of diabetes or management of hypertension. Now, these courses are all held virtually, webinars delivered from our hub in Nairobi and from our other partnering hubs in other parts of the world. What we will be doing is talking to yourselves to be able to do some needs assessments so that we can be able to know the demand and in which particular areas the training would be offered. And these trainings are absolutely free of charge. We have a hub and spoke knowledge sharing approach where we have virtual sessions, the way that like I've just said, virtual sessions to educate primary caregivers. In view of the social distancing challenges that we have now, we do encourage virtual training rather than having people coming and congregating or traveling, to have their training. So once we have the needs, we'll be able to schedule these training sessions, and then these can then be held, virtually. Of course, you'll need to have it either on a laptop, a tablet, or a smartphone to be able to engage with us at the training hub. The idea here is to increase the capacity of health workers to deliver best in practice care. There's a series of trainings going on right now on management of COVID-19, and so there's a whole range of training virtual training opportunities. And once we engage with the hospitals, it will be possible to prioritize and to prepare schedules for these trainings. And so, like I said, our milestones currently are that in the first quarter of 2021, once we've put pen to paper on the partnership, which we'll do tomorrow, there will be a training needs assessment. We will be then registering members both for the training and for the group procurement, to enable us to start the operations. And so our motto is equal access to quality care for everyone. Thank you very much, ladies and gentlemen.
Thank you, Sam. You really kept time. Awesome, thank you, Sam. All right, so friends, colleagues, we are getting towards the end of today's presentations. We are going to have a small feedback session at the end. I don't know whether we have presenters from Intermedica. Beatrice, you ready or you want to go tomorrow? Today? Okay. Now, as Beatrice comes to set up, one of the interesting things about what Sam has just presented, this idea is coming from what we discussed last year. One of the suggestions, if you remember when we were on the other side, those who were there, when we were talking about group purchasing, do you remember? I think you do remember, isn't it? We talked about how can we bring ourselves together and potentially buy things in a bulk format and make it cheaper for everyone, okay? And we have been talking about setting up our own logistics agency for Rupha. And we think we found a potential partner who can help us, finish the journey. What CDMS have done is to develop this platform they are calling TIBANet. And then so on the TIBANet platform, anywhere around the country, you can go ahead and order medication from different suppliers. Now, what we are still trying to figure out, and this is a discussion we are still having, is how to handle the logistics. And in general, we seem to think that as an association, we can, together, maybe invest in the logistics side of this, so that, this is like when you're buying goods on online. Okay, let's say you're buying from Amazon, for instance, this kind of model. You will go in, you find items, you pick. They are from different suppliers. And the approach here is aggregation allows you to find the cheapest rate in the market. So for example, if you want to buy amoxicillin, we have X number of vendors in Kenya, but you never know for sure if the one you're buying from is the one offering the best price in the market. Maybe you buy because of trust and history. But with this kind of platform called TIBANet, what we are thinking will happen is you'll be able actually to even rank the goods in terms of, let's say, price, from the lowest to the, or you can rank them based on other things, originals, things like that. And then you pick, and what you might end up finding is you have a basket of goods which you want to come to your facility, but they're coming from 10 different suppliers. Now, we are discussing that it's probably more prudent, because you don't want 10 different boxes coming from across Kenya to your place. Things can get lost in that whole process. You might want them to come as a single package, the way if you order goods on Amazon, it happens. So we think that we could come up with this logistics arm. The other thing we have to think about is, and Sam knows this, we discussed, drugs, we buy our things mostly on credit. You guys know that, isn't it? Your suppliers, you have credit relationship. So we are thinking through it, because if you're buying on Amazon haijaipatia mtu deni. You pay cash, the story is over, isn't it? So we have to think about how do we get drugs to our facilities on some form of credit basis. So those are the discussions, but we think this is the steps we want to go forward. Welcome, Beatrice.
Thank you so much, Dr. Brian. And before I start, I know I'm the last person to present today, and how many minutes are you giving me? We had this discussion with Ezekiel, and I told him probably I'll take the whole day just talking about Intermedica.
You can even present when we have left.
It's okay. First and foremost, I would like to say thank you to the Rupha leadership just to have this happen. When we started the year, we had this in plan, but along the way, we lost it because we thought because of the ongoing pandemic, it would not come through. But he reached out to me and told me we are on course, so you can always come and join us in this. So I would like to say thank you to the leadership bit of it, and at the same time to the members who also had to consent for this to happen. Without their consent, I believe I would not be here today. So who is the Intermedica? To start it off, I would say that we are an international company that deals with the laboratory equipments, and that is where we pride ourselves. And the fact that you're an international company would come in with the aspect of us being a manufacturing company. So we manufacture all that we produce and all that we sell in this market. And whoever deals with us has that assurity that you're dealing with the owners of the machine. We can always come in, dismantle your machine at any time and then bring it together for you. So whenever you come and deal with Intermedica, we can actually assure you that you'll never dump your machine just because of a technical support, just because of any spare part missing that you cannot be able to access. We are here and we are always going to be settled out. So just to take you through who Intermedica is and where the whole story begins and where we are and what we are looking forward to achieve in the future. So if you look at this here, this is the new location of Intermedica, but the whole institution is based in the US, but we don't operate on the name of Intermedica because the whole company started by the name HTI, and HTI means High Technology Incorporation. This is what we are registered with back in the US, where we do all the manufacturing of all of our items. Then now the company thought wise that they should come up with a subsidiary company that's just going to take care of the distribution part of it. So that's where the name Intermedica originated from. So the first company of Intermedica was set in Russia, and then they moved to Ukraine, they moved to Russia, not Russia per se, sorry. They moved to Kazakhstan, then they came to Kenya, and currently we are setting one in Mexico. Because of Corona, we are unable to do it as we thought, but hopefully before end of the first quarter come next year, I know we'll be ready and we'll be able to serve the people in Mexico. So HTI started as a family business and it's still being run as a family. It started from a father and a son who had the idea in mind. They started by selling other people's product, but along the way, they decided that they would come up with their own because they believe that they have the capacity and there's an opportunity there. So they decided to go ahead just to grab the opportunity that is available for them. So if I would take you very fast to what happened through this company, where they started, where I say it started with a father and a son idea, and then they've built this all the way to where we are currently. So they started small, and then they grew slowly by slowly, depending on the opportunity that they were getting across and what they could be able to pursue at that particular point. So the company itself has been there for the last 24 years, and this is the growth that it has had all this through. If you go to US, you talk of HTI, but if you move outside US, then you talk of Intermedica. The manager is still the same. So this has been the growth of this company since it started back in 1997. So if you look at this, then the dream of this son and father did not just happen overnight. It's something that has taken them time. And the reason why I'm trying to show you this is just to assure you that we've been here for the shortest period of time, but we intend to be here for the longest time. Because for them to start all this way, where they had nothing, selling someone's business, and then they move all this up to the 24th year, then would really show you that these people, both of them are still alive, so they have a vision. So them presenting themselves in Kenya would actually assure you that they're here to stay and not to run away, which was really difficult to convince some of our customers when we started, because they thought we coming in, not giving them what they expect, and then would carry our things and go away. So I had to assure them that this is going to happen. And so far, we've started our 4th year, and they are still getting back to our conversation by then. And we believe that some of you who've not yet come on board to work with us would come to get this information now when others have already believed, and now we'll both join together and walk in the journey. So if I could take you back just to mention to you on what we do when it goes to the lab, we manufacture lab equipments and reagents, but we really don't do the whole package of lab, but we believe that we do quite a number of them. So our strength is in the hematology section of it, where we only have 3-part machine available at the moment, but we're working on the 5-part machine. Due to the regulations that we have back in the US, it has really taken us time, almost 2 years now. The machine is not yet out for the 5-part, but we are hopeful that come next year, it will be available in the market. So apart from that, we do the coagulation machine, which forms the homeostasis part of it. We have a machine that runs on a 4-channel. You might have heard of a 2-channel, but ours run on a 4-channel. So you are capable of doing 4 tests simultaneously. Then you also do immunochemistry bit of it, which has been a challenge to us. Every time I approach customers, they give me a budget of a point of care, which we still don't have. We run on semi-automated one. But you are still hopeful whatever you brought into the country, one day someone will come out and buy them. And our next product is the clinical chemistry, where we provide 4 different models, starting with the small one, and then now advancing to the fully automated one. And then now we do urinalysis, sorry. We have not indicated a microscope and a centrifuge here because we come to the market with them, but you offer the high end. If you are to go for a microscope, then you'd be talking of Olympus CX23. That is where I start pricing my equipments from. So The upcoming facilities tend to shy away to work with us in that direction because they feel that you are so expensive. But those who are starting and they know what they want to go for a long time thing, would always come on board and work with us. So at times we put them aside, but if you visit us, we'll tell you we still have them. So if you really know what you want to go for, if you're looking for quality and a long-term business project, we are the people to work with. So this is our this is our 3-part machine, and the 5-part is coming in the same picture. Only the operation bit of it would be different. So it look pretty much the same, but now if you go downward here, we have a mark that is written micro CC 20+. So the next one that is coming, the 5-part, will read micro CC 20+. So we include it here because we know that it's something that we've manufactured. We are just waiting for it to be allowed so that it can be exported to us so that we start selling it. But for the meantime, if you go to our manufacturing site in USA, you'll probably find it in the stores, but we cannot sell it. So if you go to the next one, we have quite a number of reagents because other than our own reagents that runs on micro CC 20+, we also manufacture reagents that work in any other open system. So if you have an open system machine, feel free to talk to us. I know we always have a good deal on the same. And then before I leave the 2-bit of it, I know we have not coagulation per se, but a control that works in this particular machine. And I would come to you and tell you that I offer the best when it comes to the controls because what we have in the market has the longest shelf life. I'm receiving a package that is coming in next week, and the shelf life is going to be 5 months, expiring next year in May. Would not want to go for that. And then the next one, now we have our chemistry machine. I talked of the 4 models. We have the small one by chemistry, and then now the 3 different models for fully automated. And then these are the reagents that we offer for chemistry reagents. But as much as they work on our own machines, most of the chemistry machines that we have in the market are open system. So if you want to try out our reagents, come, we shall talk and give you a better deal. And then here we have our urinalysis machine. So we have 2 of them there. One we call it CL50, the other one is CL500. So the CL50 bit of it run on a 1 tray, whereby you can only place 1 urinalysis machine at a time. But the CL50 has a bigger tray. It can pick quite a number of strips up to 13, but it will be analyzing them one by one and printing out for you for results. Then if you go to the strips that we offer for the 2 machines, we give 4 of different category. But in Kenya currently, we are using H10 and H13 because most people assume the added 1 parameter for para 11, and then the 14th one, we've not yet gotten someone who wants to go for it. So if I go for the para 10, that is the normal one that you get in the market. And then if you come to the para 13, we have an extra of microalbumin, creatinine, and calcium. So if you want to come out to be unique, then that is one of the strips that you'd want to run for. Then you have our electrolyte machine. It is a 5-parameter electrolyte. Some customers would prefer a 3-parameter machine, but we tell you that the standard that we give is a 5-parameter. If you want me to remove for you one of the electrolytes, then I can tell you that the next time you're coming for it, you are going to pay for it. Whatever price I'm giving you is the same, whether it's a 3-parameter, whether it's a 2-parameter, whether it's a 5-parameter, it's still the same. So you'd better go for the package as we give you because we believe it will really give you the right service. So if you look at this, the blue part of it is where we have the direct representation of HTI. And if I say direct, it means that HTI office has their own office set in some of these countries which are here. So here we have Ukraine, we have Kazakhstan, we have Russia, and then now we have Mexico coming on board. And then in Africa, we are only based in Kenya with our office, but we still work with quite a number of distributors in Africa. So if you look at the green part of it, these are our distributors. So as a company, we thought of opening another branch probably in Ghana or Nigeria, but we yet to resolve that Kenya will be the main office in Africa. So Kenya is going to be the center of training when it comes to those customers who want to work with HGI across Africa. So in the near future, of course, we are going to expand so that you can offer full technical support to any client who is within Africa and they would want to go for HGI products, so that this way they will feel that this particular manufacturer is very close to them. So these are some of the pictures of the countries where we are represented. And then this is just the picture of HGI back in the US. Of course, they started from somewhere and they've grown up to an extent whereby they have their own place. So they've built their own offices. So this is now how that building looks like. So this just shows you what you have for the hematology department. So these are the QC labs that we have. This is for urinalysis, this is for hematology. And then here is one of the manufacturing sites. There's someone there who's just trying to pack our reagents. And then there's one here and there's another one here. And then this is our QC department for the biochemistry bit of it. And then whenever we receive our reagents into the country, this is how they are being packed. So this is one of our branches in Russia when they were having just their exhibition. I know we just try and show people this so that they can have a surety of what we are saying. We might talk about Intermedica Russia, but you start asking yourself, are they existing or not? So this is a manufacturing site that you have in Russia, because this is where Intermedica was set up first, now the subsidiary company, and they've gone to an extent whereby they have their own plant and they can be able to manufacture their own reagents. So this is the QC lab that you have in our office in the Russia. Then we have the Ukraine bit of it, Kazakhstan, Kenya, and then the upcoming one, which is now Mexico. So without much ado, I would say that if you work with Intermedica, then you are always sure of quality, that is one, cost effectiveness two, and then full technical support. This is our machine. We don't need anyone to give us anything on it. You can always come in and do anything with that particular machine. We leave your facility, you are all sorted. You are most welcome to work with us, and we'll say thank you so much.
Thank you so much, Intermedica. Members, we now want to switch gears a bit, and we want to get to a place where our consultant, Dr. Francis Kangure, is going to come and take us through a brief journey on how we got to a place where we developed our own strategic plan, a strategic plan for 5 years. Dr. Kangure, I left him somewhere behind there. Oh, here he is. Dr. Kangure is a friend of Rupha and a consultant. Yeah, a consultant in HR, and a lot of things we are working with Dr. Kangure and his many establishments to make sure that Rupha is in a better place competitively. When I say Rupha, I mean all the facilities that make up this wonderful family of Rupha. Last year, we began a journey whereby we started working on our strategic plan where we want to see ourselves in the next 5 years. And Dr. Kangure has been a great resource in this. And we want to give him an opportunity to share with us the journey that has been briefly. But then if you look at the WhatsApp group for Rupha and also the Telegram group, you will find that we have shared that strategic plan in soft copy. You will be able to see it there. So tomorrow is when we will discuss it at length together with him. He is going to rapporteur that session, and we will discuss and look at it before we launch it later in the afternoon tomorrow. So he's a good friend of Rupha, and I want to allow him a few minutes just to present to us the little journey that we have come through. Not forgetting to let you know that we want to be out of here by 5:30, so we are not taking much of your time. 5:30, we should be out of this place. So karibu sana daktari. Let's put our hands together for daktari.
You can use this one. Just use this one.
All right. Good afternoon, everyone. I know you must be tired by this time, but just requesting for a few minutes so that we can recap on what we did last year. I was very, very excited this morning, especially listening to you, listening to various presentations by NHIF, by the representative of the CAS, and the lady who talked about the Health Act, number 21 of 2017. There are 4 things that came out very, very clearly in my mind. One of them is compliance. Very, very important. Compliance in terms of provision of healthcare services, and compliance in terms of management of human resources in your institutions. Number 2 is the issue of data management. And the NHIF talked very passionately about data and monitoring of services being provided in our health facilities. A very, very, very important aspect that we thought through the strategic plan, and we are going to see how this is coming out, the issue of compliance, the issue of data management. And the other thing, of course, and it was mentioned here a number of times, is the business model. Healthcare service is a business. And when you are in a business, you want to improve efficiency, you want to improve your service, and you want to make the customer happy. That issue is well also properly addressed in the strategic plan. So I want us to recap, think about this strategic plan, what we did last year, and then we will be able to get your feedback tomorrow morning, because we may not have a lot of discussion. And then if there is anything that you would like to include that was left out by any chance, I think we can do it. And finally, I think somebody also this afternoon, and this was an issue that came up during last year's convention, is the issue of supply chain in healthcare service. And you are lucky that you have the numbers, so you can be able to take advantage of economies of scale. Very important aspect, and all the other services that were presented to us this afternoon. So just to go back to 2019, you remember we met in Westlands on 6th to 8th of November, and we sat together and we had a lot of group discussions, and members came up with the specific areas, specific strategic objectives that they want this association to achieve. So what we did, what I did myself, is to reduce this into a strategic plan that was properly socialized with the executive committee through various meetings, and we came up with a strategic plan that we are going to launch tomorrow. The other thing, and the vice chairman has mentioned, this strategic plan was shared widely to the membership so that you can be able to give your input, because it is very, very important for you to participate. And I confirm that this has been a participatory process because we started this together. So what does this strategic plan contain? In a nutshell, the first thing you see in this strategic plan is the vision, mission, and values. And the members here came up with very exciting vision, mission, and values. And you can see the bottom line, what you're trying to address is improved service, healthcare service in our communities, because they are resource deprived. So you want better service for your clients and your customers. So the vision is a society of health communities where all individuals reach their highest potential for health. Very, very exciting vision for this association. And the mission is to advance the health of and to provide leadership in health issues affecting medically underserved areas and populations through resource mobilization, advocacy, education and research. Today I was listening to the chairman, Brian. You did a lot of advocacy for this association. To the government leaders who are here today, a lot of advocacy. And you came up with specific issues that members would like addressed. And this shows that the leadership is in touch with what is happening on the ground. So that's what we call advocacy. And it is one of the key issues that came out in our last year's meeting. Then the values, equity in health, partnership and collaboration. I think all the people who spoke this afternoon, especially the service providers and the people who support the supply chain, what they are looking for is partnership for mutual benefit. And this is very important. Then professionalism, passion for excellence. The NHIF officers mentioned the standardization of healthcare provision and their specific documents that they referred us to so that we can be able to read, understand, so that we can be able to provide service with excellence. What are the driving forces for this association? Clearly, one is affordability, very, very important because of the communities that we serve. There are very few people who are able to afford healthcare service in Kenya today. They're looking at the poverty levels, and especially where you are working as members of this association. And therefore, this association is looking to pull together and create economies of scale. And we have mentioned this. Then new technologies. That is automation of systems. I was listening to smart applications, and they have presented a very exciting system that we can be able to use as healthcare providers. Then benefiting the communities where we are working. And one thing that has come out during this COVID period is the importance of healthcare providers world over. And I think it's a profession that has been recognized, and the people are looking back to see how are we supporting the healthcare providers. And this is very, very important. So at the community level where we are working, how are we serving those communities? How are we relating with them? And how do they feel about our service? Patients at the center of our service is part of the customer service. And this is also important for the business. If the customer is not happy, the customer will not come back. The customer goes to the competition. So when you put the patient at the center of everything that you do, you are sure that these patients will come back if they have an issue, and they are going to refer somebody else to the service. So the strategic priorities that we identified together, and we have tried to give some weight in each of the priority areas, and this can change. These things are dynamic. One of the most important priority area that came out is resource mobilization. The other one that came second is fostering collaboration and partnerships. Very, very important, the economies of scale. Somebody mentioned here, that is smart application. They talked about a concept called multi-tenancy. Multi-tenancy concept is a very, very important concept when we talk about the systems. It's like the association buying a single system where all the other members can be able to plug in, and this drives down the costs. Very, very important. I'll give you a simple example. If you wanted to procure a recruitment system, each of the members seated here is a very expensive system, but the association can be able to procure a single system, and the members can take advantage of that system to recruit using that single system at a small fee. So that is the advantage of collaboration and partnership. Capacity building and leadership. Capacity is very, very important. I was listening to NHIF, and they talked passionately about various issues affecting healthcare. One of them being fraud, the issues of data, the issues of declaration of the specialists that we have in our healthcare settings. For you to be able to succeed in these lines, you have to continually build the capacity of the people who are working for you, because a malpractice is as a result of poor training or lack of training or inadequate training. So capacity building is very, very important. It came out as a strong area. Then advancing affordability, service delivery and payment reforms, performance improvement, very, very important, and shaping the future of the workforce in the industry, and again, automation and advancing technology. And I'm going to break this down, these strategic priorities down into specific objectives, and the details will be found in the strategic plan that we are going to launch tomorrow. Resource mobilization. There was a need to come up with a microfinance to pool resources for the members, and we have put this down in the strategic plan. There was need to grow the membership by the end of next year to a specific number. You'll be able to see those numbers as I make this presentation. Establish a billing and claims agency to process the claims on behalf of the members, and the efficiency in correction of annual subscription from the members, because the association has to be sustainable, is sustained by the members. For it to be able to play the role of being an advocate for healthcare providers, then it needs resources through subscriptions and otherwise. Fostering collaboration and partnerships, very important. The association is looking to sign agreements with NHIF, very, very important, because I know this has been a thorn on the flesh for many members, and they would like this to be done. Then pursue and obtain formal recognition by the ministry by the end of next year. Have in place various memorandums of understanding in strategic areas, and one of them is automation, supply chain, and other services. And you have heard from the people who have presented that if you are able to buy in bulk, then you drive the prices down, and that is advantageous for you as an institution and also for the communities that we are serving. Then database. When we have a good database, even when we are required to provide data and information to various stakeholders, including the government, it's very, very easy. It's at the click of the mouse. You are able to say that in this association, we have this number of specialists. And you can be able even to tell where they are at the click of the mouse. If you want to establish a good referral system for the Rural Private Hospitals Association, you have to know where everybody is so that you can be able to refer effectively. Very, very important. And you heard that the Health Act talks about referral, which is very, very important. And so many other things. The other thing is about fostering collaboration, is developing a system of tracking benefits. What are the benefits to the members if the association partners with smart applications? We should be able to track those in terms of value. What value do members derive from these partnerships? Then the association is looking to form an internal public relations team by December 2023. And this is so important. Member relations is important so that your issues are addressed in good time. And if there are issues with other stakeholders, this team is able to address them quickly and effectively. Very, very important. Then, of course, I talked about the numbers, increase the number of members by about 1,000 by December 2025. And the numbers are clearly broken down in the strategic plan. And it's not only the leadership that is seated here that can be able to mobilize. It's each one of us who can be able to mobilize for members to join, because there is strength in numbers, as you have seen. Then capacity building and leadership development, very, very important. For us to be able to run good businesses, we have to build our capacity to do that. So we need to identify and work with specific collaborators for continuous professional development. And I know in healthcare service, continuous professional development is a very important factor. You have to go through certain professional programs every year for your license to remain valid. And therefore, it is good to look for partners who can continuously train and build the capacity on medical practice, leadership, supply chain management, referral systems, very, very important. Health records management using the system, and part of that is what has been presented here. Financial management. I don't know whether doctors go through the courses on financial management in the medical school, but it is very, very important because you are running a business. HR management. I'm a HR professional myself. I know the value of people. All the things that we are talking about here, the issues to do with records. People are the ones who keep records. So if you don't have qualified person to keep the records, you'll never get good records. Even if you procure a good system, if the person managing that system is not properly trained, doesn't have the right attitude, it's not going to make much difference. A human being is very, very important. When we talk about fraud, who commits fraud? They are people, because of where they are coming from. And that is why we need data. That is where we need to follow up and document details of the people we are working with as an association. For us to be able to create what was called a mark of quality for this association, we have to carefully select the people that you are working with. We have to have in place the procedures to deal with malpractices and so on and so forth. And there are so many other areas that can be identified for collaboration. Affordability is also very, very important. And one of the things that we have seen is that we can have an MOU for e-procurement platform. And the last presenter actually talked about this. They are called e-TIBA or something like that. Very, very important. And also the issue of equipment financing, very, very important as a business model. There are some equipment that you cannot be able to buy at once. And therefore you need a financing model for you to do that. And finally, the issue of the microfinance or SACCO for the members is very, 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 very important. And it can be able to support the members to grow in terms of financing specific projects and supporting members during crises like the one that we are facing currently. So when we have a strong SACCO, it can put the members together and each one of us can be able to grow. Service delivery and payment reforms, very, very important. Identify a private insurance health provider and formulate an MOU by December 2021 to have one identical card across the rural hospitals. This is very, very exciting. Imagine when you have a single card, and if I visit any of your hospitals in this country, I can be able to receive the same care, the same quality I can be able to receive in Nairobi, because I have a card labeled Rupha, and this signifies quality. That is what we are looking to achieve. So this is very, very important, and anybody can be happy about this. Not only you as the service provider, but us as the clients who come to visit your clinics. That I know if I go to Nakuru with this card, I can get treatment, I can get service. Then uniform insurance card, that is what we have already mentioned. Then performance improvement, very, very important. There are some organizations, and when I was discussing with Brian, he was able to mention a few. There are some standardization organizations who are known internationally, like SafeCare, GSI, and others. And we can be able to enter into an agreement so that they can support us in quality and standardization. And a lot of people that we serve in the rural communities do not find a need to come all the way from Joro and come to Nairobi for some specific service that can be provided in Joro, because we have standards across and we know who can do what across the country. Then software solutions are very, very important. We have mentioned this. We can have a single platform for learning, continuous learning. We can have a single system for something we call balance scorecard. And balance scorecard looks at 4 things. It looks at the people, who are the people working for you and how are you managing them? How are they improving in terms of performance? It looks at finance. It looks at the customers we are serving, and we are able to track how we are able to improve in terms of quality. And it also looks at something very, very important. It's called internal processes. How are the procedures among our members when a patient reports in your clinic? And when you look at the laws regulating the medical practice, there are specific procedures that must be followed. There is a specific documentation that are required. Therefore, these softwares are very, very important for every member, and they can be done through a multi-tenancy arrangement. The issue of health records management, we mentioned that, and also the issue of a referral system. All this goes towards improving the performance of our facilities. And finally, automation and advancing technology. We have already talked about this. We can have various technologies. including the ones that we have been presented today. And one of the other technologies that we can be able to utilize is HR technologies. And I mentioned recruitment. Apart from recruitments, there are others like records keeping. The law requires that every employer keeps accurate and updated records for everybody you employ. If there is an issue in your institution, there is nobody who is going to ask the employee about the letter of employment or the contract. They ask the employer. If the employer doesn't have that document, it's a big issue under the labor laws. And a part of that has already been domesticated in the Health Act of 2017, how to manage HR within the medical practice. Very good. And then on board all members of the association to a multi-tenancy system by maybe December 2025, when this strategic plan comes to an end. So it's a gradual process. We have put the details in the strategic plan. We have put specific timelines. And I think tomorrow we'll be able to interact with the document more. And I know some of you have read through. And so basically, that is what this document contains. I know the chairman has advised that you have a question and answer session, but perhaps you could allow two reactions from the membership. Two, three questions or a quick reaction, and then tomorrow we are going to discuss further.
Thank you very much. My name is Muriuk from UNAS Medical Center. This is wonderful. I find it very highly loaded. And I thought it was good to start either the one or two which can be achieved within next year. I think this year is gone. Because if you take all those things, some of us might have it a bit loaded and it might not be achieved. But if you take one or two, especially the issue of a circle, that can be great, or on drug agency for the Rupha members. Because you have so many things that have been put down. If you try to implement all of them at tango, they might not be easy. Thank you.
Good evening. Yeah, I think what you have talked about is really great. I'm looking forward to full information tomorrow. What I'm just requesting is as opportunities open up as we venture into those things, give priority to Rupha members and those people who are going to be maybe proposed by Rupha members, because it's coming with many opportunities. Thank you.
Very good. Thank you very much. Those two comments are very, very important. And I want to start with the one from Daktari. Daktari says that this strategic plan is loaded with a lot of activities and strategic priorities. What we did, and when I looked at all the feedback that was coming last year, we had the same feeling together with the executive committee. But we said, this being the first strategic plan, it is important to document everything that you raised. We may not be able to achieve everything at a go, but I said there is a plan with very, very clear priorities and timelines, and this will be shared tomorrow. And we can agree tomorrow and say, this can wait, this we are able to do, but what we have here is a shopping list. And we can be able to pick what we can do in 2021, what we are able to accomplish, one or two items, what we are able to accomplish in 2022, 2023, 2024, 2025. What happens with the new organizations, sometimes when you are not too ambitious, people tend to slacken. It's better to be very ambitious. Let us be that ambitious, and then we try to prioritize and see what we can be able to achieve. But of course, I appreciate that comment, and we can be able to trim down these activities to what is achievable within 5 years. So I think the executive committee will be sitting every year in an AGM like this one, and then we agree on 2 or 3 key priorities for the year, and then we accomplish that, and then we move forward. The other comment is giving members a priority. When we are talking about all these opportunities in supply chain, in medical equipment, in services, we have members here with expertise in various areas, and you can be able to benefit this association. For example, we can introduce continuous professional development program for the association. Why should we go elsewhere to look for a doctor, and there is a doctor who can be able to train within the membership on a specific field? So we take advantage of what we have, and we utilize the resources that we have within the association. So that's also a very, very important point. So thank you very much for listening to me. Thank you very much, and God bless you.
Awesome. Thank you very much, Dr. Kangure. Like you have heard, that is a man with a lot of resource. And we'll be unveiling, rather going through a discussion about our strategic plan tomorrow morning. And thereafter, in the afternoon, we will launch it, a 5-year strategic plan. In the meantime, before I call my chairman, I just want to appreciate each and every one of us, and particularly our sponsors that have made this program possible for today. I really want to appreciate Smart Application, our main sponsors for today, for this conference rather. Today and tomorrow, they are partnering with us to make sure everything runs smoothly. And I'm glad that our members have continued to enjoy this. I also want to appreciate Hako Industries. They have really done good. They are the ones who provided the gift hampers for all our guests, and I'm sure they will bring some more tomorrow for tomorrow's guests. So Dr. Kangure hautaenda bure, something will come. And I also want to appreciate Kenya Alliance. You're also a wonderful team. I also want to appreciate Intermedica. They have done a good presentation here. UAP Old Mutual are also on the other end together with Madison Insurance, CDMS and Tibanet. Great people, we love you. Identigate Integrated Solutions. Those are the IT guys that are helping us in registration. You realize that everything is going digital. So we also went in that platform. So even our registration and everything, and even the sessions that you are attending today are somewhere recorded with the QR code that is there in your name tag. So thank you, Identigate. Jua Solar. We all have a poem, a cry, or a song about KPLC. Jua Solar has come handy to support us to transition to solar energy. And please pass through there. And I know tomorrow they will be speaking. And just get to know what Jua Solar is all about. They are wonderful people. I was talking to them and they said, sooner or later, KPLC will be your backup power. You will be using solar. You're just having KPLC when, for a change. MedSource, EcoMed, ECL, Mustec East Africa, Ilara Health, we really appreciate all of you and thank you for partnering with Rupha. Next year, it will be great. It will be bigger, it will be better, it will be great. So we look forward to partnering with you, and I want to encourage all our members, also support these exhibitors. Before you go home, wherever, go visit them. Pass there so that they can also see that they really invested their time and their resources to people that are willing to work together with them. So I want to encourage you, even before you leave, to go home, pass through there, see a few things, get a few contacts, and follow up and make your business good. So without much ado, thank you. I'm also reminded that you don't lose your tag, because this is what you will use tomorrow. There is a QR code there, which is very important, that is going to help us analyze a number of things that we will be doing it during this conference. So please don't lose it. Come with it tomorrow. Again, we'll be using it for the same, and it will be a good thing. Let me bring in our chairman to dismiss us for the day.
All right, thank you, Vice Chair. My duty is very quick. It is to prepare us for tomorrow. I don't know if you have a copy of your program. Please just pick it up. Let us look at what we are up to tomorrow. I just want to put your mind ready for the events of tomorrow. We intend to finish the events tomorrow by hopefully by 1 p.m. or if we are late by 2 p.m. Depending on when our guests arrive, but we are really working to make sure that by 1 o'clock we are through this. It will be a very tight program. I just want to highlight one of the items that Dr. Kangure was to present, rapporteur rather, which is the member resolutions, the 2:30 to 3:15 p.m. item is what we shall start with tomorrow after listening to some of our sponsors who have not spoken today. So take note of that. When my friend Muruki was speaking about the way the thing is packed, I think you read that item 2:30 to 3:15 member resolutions on the strategic plan. This is what we shall engage in. Dr. Kangure has presented a very broad framework and it is a 5-year roadmap. But it is us, it is you who will decide out of all those many things, what should Rupha focus on? Okay, that is the critical item there. We are allowing a discussion there. Give the mandate to the association that, fine, all these are wonderful ideas, these are great ideas, but we as the members, we are going to commit together on this 1 and 2 priorities for the next year. So that is something we will do tomorrow as we unveil the strategic plan. The other very important thing that we are hoping to have tomorrow is, if you go to the back page there, I want to skip you to the last 2 items. The last 2 items there, presentation of management accounts of the association. Okay, that is a very critical item. I think for 18 months we have been running, members have been contributing, membership fee, subscription. The rules of the constitution of the association provides that at every AGM, these accounts should be made public and discussed. So this is what we are doing tomorrow. There will be a presentation on our finances. If you remember a funny joke, last year, we didn't discuss that item because we had no money. Do you guys remember that? There was no money to discuss. So we said, let's defer until the other time. I think this year we have something to discuss. So I hope you can look forward to that. And then the other item is election of regional coordinators and members of the executive committee. Now, let us put it this way very simply. Personally, my term in office ends tomorrow. Okay, to put it very simply, the term of the executive committee that you have here ends tomorrow. Those are the rules of the association. But we are hoping that you will all stay around tomorrow so that those of you who feel that you can provide leadership, you can give direction, this is the opportunity. We need more leaders for the association. The more leaders, the ideas, people who have a right vision for this will help drive engagement. So the constitution provides that we should have regional coordinators for Rupha. And I would encourage you to to get a copy of the constitution tonight and just peruse about the issue of officials and elections as we prepare for that. As per the constitution, only those regions which have at least 5 members are eligible for electing a regional coordinator. So we've gone through, and I hope that was circulated, and we have 12 regions. Please look at that. We can circulate again. I know there is Busia, there's Mombasa, there's Kilifi, there's Kirinyaga, there's Nakuru, which is the other one? Meru, Kajiado. There are quite a number. Just check on the list. Wale ambao wanasikia mwito wa uongozi, unasikia unaungua kabisa, you want to lead like yesterday, this is an opportunity, and we really need these regional coordinators to drive the association and to organize at the local level. Tomorrow we are doing that. So very important agenda. The last important agenda I want to raise for tomorrow is the press conference. That is the item supposed to happen at around 10:30 to 11. Now, this is going to be very important item for you to be present. We are going to address the media. We have invited them. We will be joined by members of the KCCB, that is the Kenya Conference of Catholic Bishops. We hope to be there. The Christian Health Association of Kenya, CHAC, Mission Hospitals. CAF, our brothers in the private sector, have already confirmed they will be joining us. We will have the chairman of the Law Society of Kenya present. We will have the Secretary General of the Kenya Medical Practitioners and Dentists Union, Dr. Chibanzi Mwachonda. I'm sure you have been seeing him all over the media talking about healthcare workers and COVID and safety. So this is likely to be a very well covered press conference. I think you don't want to miss it. It's a great opportunity for us also to place the agenda of Rupha center of the national conversation. So thank you very much for your attendance today, tremendous attendance. Thank you. Chai iko ama ilienda? The chai is still there for those of you who have some time to grab a cup of coffee or tea. As the vice chairman said, please pass by the stands of our exhibitors, Ecomed, pass by, all our supporters, Jua Solar, Intermedica, etc. I want to welcome the vice chair to close us with a word of prayer. Please let us be upstanding.
Let's give thanks as we close our day. Our Heavenly Father, in Jesus' name, we thank you for seeing us through from the hour we woke up and we started this convention to this very hour. And as we close our first day, we want to say thank you. Thank you for every speaker that has spoken today. Thank you for every presentation. Thank you for every member that attended the sessions today. We thank you, Lord, because you kept us alive so that we may do this. And as we bring our minds and our hearts together so that we can transform the healthcare sector in this country, we pray for your wisdom. We pray for your guidance. We appreciate you, Lord, that as we break our ranks now to go to our respective places, we pray, Lord, that you may watch each and every one of us, protect us and secure us. We look forward, my Father, for tomorrow. We pray that tomorrow shall be better and bigger. We thank you for each and every one of us. And as we look forward to see one another tomorrow, my Father, we will thank you. We bless you and we honor you. In Jesus' name we pray. In Jesus' name we pray. Yeah, that amen will reach you home, will get you home. Thank you so much. Please pass through the exhibitors on your way. Get there, take a cup of tea and some snacks so that you get home while you're still having your energy. Thank you. Okay.
Harrison, we need also one with you, eh?
Yes.
Yes. Not with us.
Okay. Here. Here. Thank you. Yeah, karibu here katikati. Good. That is it. Wow, we really appreciate. Yeah?
Harufa shirt.
Oh, yeah, you will get one. They're still somewhere. Yeah. Okay. Oh, Kabi, come. Oh, okay. Thank you. Awesome. Okay. Film Jaisha. Okay. Thank you so much. Asante sana.
Thank you.
Yeah, we encourage you also to pass through Rupha desk and get yourself a t-shirt and umbrella and some good things there. It will be good to support the association. Thank you.